Now, today the topic of discussion is shock. It is not emotional shock, it is cardiovascular shock. It's a clinico-pathological condition in which cardiovascular system collapses and there is widespread hypoxia to multiple tissues in the body. Is that right? And this condition has very high mortality. And if young doctors have good understanding of this topic, right, they can save more lives. So, to start the topic with shock, first of all, we'll talk about the very basic about the cardiovascular system. Let's suppose this is a cardiovascular system of a healthy person, and if this is a cardiovascular system of a healthy person, I want to know that what is the cardiac output in a healthy person when he is resting. Yes, Mr. Israel?
5 liters.
5 liters. So, cardiac output is excellent, 5 liters per minute in a healthy person who is resting. And then another question, what is the, okay, Ms. Yara will tell us, what is the volume of blood in a normal healthy person? You mean cardiac output and blood volume are equal?
Yes.
Okay, I like your confidence. So, Ms. Yara is telling that volume of blood is 5 liter in a healthy person approximately, right? So, you can see it that your circulatory system have 5 liter blood and the same amount is passing as the cardiac output every minute. Now, another question is that what is the capacity of cardiovascular system in a normal person? Yes, please. Now, capacity of cardiovascular system, I am not asking about volume. What is the capacity of cardiovascular system?
Again, 5 liters.
It is 5 liters because in a normal healthy person, cardiovascular system is 100% full. You can puncture any capillary anywhere or any vessel anywhere, blood will come out. It means in a normal person, the blood volume and blood capacity of the circulatory system, that is equal, right? It means that in normal person, cardiovascular system is 100% full of blood. Is that right? Or we can say that in a normal healthy person, the volume of the blood and the capacity of the blood, they are not having any disparity. Is that right? Because if they are equal, it means all the cardiovascular system will be full. So, whenever left heart will push the blood to the circulatory system, of course, venous blood will return back to the right heart. So, is that right? Now, what can produce shock? There are so many reasons that different patients may undergo shock for different reasons. One of the reasons is that problem is disparity between the volume and the capacity. There is difference between the or disparity between the volume and the capacity. For example, if some patient has lost some blood volume, let's suppose in this patient there is bleeding or due to any reason he has lost blood out of cardiovascular system, right? If he has lost the blood, now his volume will not be 5 liter, let's suppose volume is 3 liters. Let's suppose that volume is 3 liters. Now you see, capacity is 5 liter, volume is 3 liters, so circulatory system is overfilled or underfilled? It is underfilled, right? And if circulatory system is underfilled, it cannot maintain effective pressures within the circulatory system. And if cannot maintain the effective pressures, do you think when left heart will pump to the circulatory system, if it is underfilled, attention please, will the blood easily return to the heart? No. When circulatory system is not properly filled, right? For example, I am the patient, my heart pumps the blood to the periphery, blood will go to the periphery, but because volume is less and capacity is more, so pressure in circulatory system are so low that venous return to heart is less. And if volume is less, then venous return to the heart is less and cardiac output will drop. And eventually, if this situation becomes very serious, cardiovascular system will collapse in functioning. And cardiovascular system is not functioning well, it cannot maintain its circulatory system, it cannot provide the tissues with the proper oxygen supply and other nutrients, and it cannot remove the waste products. Is that right? And widespread hypoxia will start, and we will say patient is going to cardiovascular shock. As we defined earlier, what is shock? It is a clinico-pathological condition in which there is circulatory collapse, and that circulatory collapse is resulting in widespread hypoxia and widespread deficiency of blood perfusion all over the body. Is that right? Now, I told you that different patients may have different reasons of having the shock. This is one patient we talk about that he lost the volume. And because he lost the volume, and loss of the volume produced disparity between the volume and the capacity, and that produced the reduced venous return and reduced cardiac filling and reduced cardiac output, and that is taking such patients to the shock. This type of shock is called hypovolemic shock. Volemic shock. Right? Now we come to another patient. We talk about another patient. This is our second patient. Let's suppose this patient has normal volume is 5 liter, normal capacity, that capacity is also 5 liters, right? It means if volume and capacity disparity is not there, they are properly matching volume and capacity. But this person has a real trouble with the heart. For example, he has massive myocardial infarction, and due to massive myocardial infarction, heart cannot work as a pump. Now listen, if volume and capacity are matching well, circulatory system has effective circulatory pressures, but if your pump fail, do you think you can maintain the circulatory perfusion to the different tissues? Can you maintain the supply of oxygen and other nutrients to the tissues? No. So it's not enough to have volume and capacity matching. Of course, we need heart also to maintaining good pumping action, right? In some patients, the primary cause of shock is that your heart is failing as a pump, and if there is dangerous reduction in pump function of the heart, of course cardiovascular system will collapse, and in spite of normal volume and capacity, blood will not be circulating in a proper fashion, and tissues will not be provided with enough blood, enough perfusion, enough, you can say, oxygen and nutrients, right? And we'll say patient is again going into shock. Such type of patients where the real problem is with the pump action of the heart, right? There is pump failure. The mechanism here was pump failure, right? And this was, you can say, volume failure, right? And first patient, there was volume failure. This was our first patient. And second patient, group of patient, in second group of patient, we are talking about pump failure, right? And when there is pump failure, what is the result? The cardiovascular system cannot maintain its perfusion pattern to the all body tissues, and patient will go into shock, and this shock is called, this type of shock is called, yes, cardiogenic shock. Cardiogenic shock. There is cardiogenic shock. Now we come to two more situations. So think of another patient, right? And in this patient, heart is perfectly okay. Problem is with the capacity. Due to any reason, cardiovascular system capacity dangerously increases. Now let's suppose heart is perfectly okay. The primary problem is that capacity has become, suppose capacity has become 8 liters and volume is 5 liters. Now, if volume capacity is more, volume is normal, it means again there is disparity between the volume and capacity, and effective filling pressures are not maintained. Can we maintain the venous return? No, because again peripheral pooling of the blood will be there. Now, compare the case number 1 and case number 3. In case number 1, there was also volume and capacity disparate difference, and case number 3 also there is volume and capacity difference, but in case number 1 there was loss of volume. In case number 3 there was increase in capacity, but in both cases circulatory system is not properly full. In both cases venous return cannot be maintained. In both cases, of course, secondarily cardiac output will drop. Is that right? So this type of situation where capacity has become too large and you can say distribution of the blood in the body become pathological. Distribution of blood in the body become pathological because blood is too much distributed in the peripheral tissue, peripheral vasculature, which is dilated too much. If it is so, then can you give me some example like this in which cardiovascular, especially vascular system dilates too much and blood pools in the periphery and then venous return cannot be maintained and patient may go into shock? Every doctor must know the example, every doctor, without any exception. You would like to tell me something? Yes, madam. Do you have any condition in which suddenly the capacity of vascular system increases dangerously, and when capacity increases dangerously, the normal volume is not enough to fill, blood becomes pooled, venous return is not maintained, cardiac output drops suddenly, and patient can die within short time in front of you? Please tell me anaphylactic shock. In anaphylactic shock, what really happens? For example, penicillin hypersensitivity, or if a patient has made IgE against a drug and you give that drug intravenously to the patient, what will happen to the patient? You know, if you are allergic to some substance and you have made IgE against that, then what really happens? These are your mast cells. You know, mast cells are well present around the vascular system. Write down. Mast cells are well concentrated. Even though they are present all over the body, even though mast cells are present all over the body, but they are specially concentrated around the blood vessels, under the skin, and mucosal linings. Now what really happens? That mast cells are having IgE antibodies, right? Now let's suppose in this patient has IgE antibodies against a venom, and if that particular venom enter, or that particular substance against which this person has made IgE, if that substance enter in the body, look here, that substance will activate the IgE, and IgE will stimulate the mast cells, and mast cell will release many substances, and one of those substances is, yes, what is that? Histamine. And when massive amounts of, now listen carefully, let's suppose if I have made IgE against a particular drug substance, and unfortunately you don't do allergic test and skin test and you directly infuse that drug into my blood, then that drug will go bind with the IgE immunoglobulins present on the mast cells all over the body, and all the mast cells will release lot of substances. One of them is histamine, and all this histamine which is released around the blood vessels by the mast cell will lead to massive dilatation, and blood will be abnormally distributed in the body, and will it come back? No, and we will be in a trouble. This is just one example, right? This is usually called anaphylactic shock. But listen, there are other examples also, because it's a full group, is called distributive shock. Distributive shock. Blood distribution is abnormal. The example of anaphylactic shock is just one of the examples of distributive shock. Anaphylactic shock is just one of the type of distributive shock, in which there is again volume and capacity disparity, and major reason being that capacity is dangerously increased. Can you tell me some other condition in which capacity is dangerously increased? Please tell me neurogenic shock. In some conditions, if sympathetic nervous system fails, for example, if someone wants to commit suicide and takes a high dose of sympatholytic drugs, sympathetic tone is lost, all the blood vessels dangerously dilate and patient will go into Neurogenic shock. So neurogenic shock is again a type of distributive shock. Is that right? The real mechanism is distributive problem. Okay, tell me any other reason of where there's distributive shock, where cardiovascular system, vascular system pathologically expands and blood is lost in the periphery and venous return cannot be maintained, cardiac output cannot be maintained. There is one condition which is so common, so well known. We have just talked about anaphylactic shock, which is a type of distributive shock. Then we have talked about neurogenic shock, which is again a type of distributive shock. Can you tell me some other example of distributive shock? Please, please, please tell me septic shock. Septic shock, everyone should know, isn't it? We are becoming doctors. Septic shock, when there is some septicemia in your body, when a lot of bacteria are there, especially gram-negative bacteria which release a lot of endotoxins, then endotoxin-induced cytokines are produced and that produces massive vasodilatation, right? In septic shock, one of the problem is that a lot of blood vessels dilate, because in septic shock, we'll have a full lecture on septic shock later, right? I'm just introducing the types of shock. We'll discuss in detail septic shock later on. But right now, I'm just telling you what really happens in septic shock, that a lot of toxins are present in the blood, a lot of bacteria are present in the blood. If endotoxins are there, right, they will damage all the endothelium and activate a lot of white cells, and they will produce a lot of cytokines, and these products will produce massive arteriolar dilatation and endothelial injury. So in septic shock, all the blood vessels will dilate and there will be increased what? Capacity. With that, because endothelial leakiness is also increased in septicemia, so even some volume is also lost from the blood to the interstitial area, right? So we can say that anaphylactic shock, or there was neurogenic shock, or there was, yes, septic shock. All these are the examples of distributive shock. All these are the examples of distributive shock, and there are more also, we'll talk about that. So how many mechanisms of shock now you know? Number one, volume failure, hypovolemic shock. Then we said that pump failure, cardiogenic shock. Then capacity failure, pathological increase in capacity, and distribution failure. So we call it distributive shock. Any other cause of shock you can tell me? Okay, we talk about one more patient. And now you have to use all the layer of your cerebral cortex to answer this question, right? In this patient, cardiac output is okay, heart is okay, heart is healthy. In this patient, myocardial pump function is okay, pump is capable of doing its function. Again, in this particular patient, there is no primarily pump failure because myocardium is healthy and able to pump. Capacity is normal, volume is normal, still shock occurs. Of course, it will not fall into any of the first, second and third category. What could be the now mechanism? We have said there are four mechanisms of shock primarily, right? One mechanism is volume is lost and volume capacity disparity. Other is capacity is gain, again volume capacity disparity difference. Pump fail, so either volume fail or pump fail or capacity fails. And then one more type of patient, he is in shock, cardiovascular system is not working, cardiovascular functions are collapsed and arterial perfusion to the most of the tissues is not maintaining, and patient is having widespread hypoxia and nutrient deficiency at a dangerous level. But this patient had initially normal pump function. He had normal capacity and normal volume. What could be the mechanism? Yes. Yes. Anything comes to your mind? Heart failure, if you put heart failure, that is cardiogenic shock. Pump failure, isn't it? That will fall into this category. So it is not heart failure. Okay, I will tell you something. If we really put some obstruction to this system, even though pump can work, volume is okay, capacity is okay, but lumen is obstructed in a dangerous way. Cardiovascular, for example, pulmonary artery is blocked by a very big embolus. Pulmonary thromboembolism, have you heard of it? There is a massive embolus from deep venous thrombosis. A big thrombus has embolized from the deep veins of the leg. It is not a rare thing. And this right heart pumps this thrombus into pulmonary artery and it blocks the big portion of pulmonary artery. Now, heart as a pump is okay, volume is okay, capacity is okay. What do you think? The tissues will be well perfused? Not at all. There is obstruction. What is there? Now, the problem is obstruction. Is that right? And when there is obstruction, we should call this condition obstructive shock. We should call this condition obstructive shock. Now, listen carefully. These are just 4 basic mechanisms of shock. Let me now repeat the basic concept. What is shock? Shock is a clinical pathological condition in which there is cardiovascular failure. There is cardiovascular collapse resulting into so poor peripheral perfusion, arterial perfusion, that even tissues are not receiving the minimum amount of nutrients and oxygen for their metabolism. That means cardiovascular collapse is leading to generalized hypoperfusion in the body. What are the 4 mechanisms? Look here again. Either volume is lost, or heart pump function is lost, or capacity is dangerously increased and effective pressure in circulatory system is lost, or there is major obstruction to the cardiovascular flow system. We say lumen failure. What is there? Lumen failure. Lumen failure. So there can be volume failure, patient number 1, pump failure, patient number 2, capacity failure, patient number 3, lumen failure of cardiovascular system, patient number 4, right? Now we will talk about the common causes of hypovolemic shock. Hypovolemic shock. Now, what could be the common causes of this? Right? Now, this is the patient in which problem is with the volume. The volume of cardiovascular system is reduced, volume loss from cardiovascular system. Is that right? Why the volume is dangerously reduced? Now, the simplest cause is hemorrhage. The simplest cause must be hemorrhage, bleeding. Hemorrhage. We also call it hemorrhagic shock. Now, when we talk about loss of blood or hemorrhagic shock, again the blood may be lost from the cardiovascular system, but within the body or outside the body. So, it may be hemorrhage, and hemorrhage may be external hemorrhage, or it may be, yes, internal hemorrhage. Some people call internal hemorrhage concealed hemorrhage, right? Someone is, suppose, actively bleeding from the cardiovascular system, but if blood is evident outside, we call it external hemorrhage, or if it is accumulating within our body, right, and it's not evident outside, then we call it internal hemorrhage. The example of external hemorrhage may be, the classical example is simply like roadside accident, right? In roadside accidents, someone has severe trauma, or we can say simply trauma. We can write it more, trauma, right? And person is actively bleeding and you can see the blood, right? Or another example is sometimes GIT bleeding. If there is heavy bleeding, right? GIT bleeding. If heavy bleeding in GIT and person vomit out the blood, this is called hematemesis, right? Or person passing a lot of blood per rectum, right? If there is bleeding in lower part of the GIT, right? And sometimes the amount of the bleeding may be so much that person may go into shock, right? Then we can come to internal hemorrhages. That sometimes bleeding is going on within our body and it is not evident outside. The classical example of this is when there is rupture of ectopic pregnancy. You know, when ectopic pregnancy, for example, a lady who is having product of conception in tube, fallopian tube, and then it eventually ruptures, she will have heavy bleeding within the peritoneal cavity, right? So, example like this, internal hematomas, hemothorax, or there may be hemoperitoneum, right? As I told you, one of the simple example is ruptured ectopic pregnancy, or someone has ruptured aortic aneurysm. Is that right? It's internal example of internal hemorrhage. Now, but some people, they don't lose the whole blood, they just lose one of the major component of the blood and then become hypovolemic, right? There are conditions in which there is loss of plasma. There is loss of plasma. Loss of plasma. Can you tell me some conditions in which there may be massive loss of plasma out of the cardiovascular system, and of course cells are left behind, so there is a hemoconcentration and hematocrit become high. Again, I am asking you a condition in which some plasma is lost out of cardiovascular system and remaining cells in the cardiovascular system, they become too much concentrated and there is hemoconcentration, hematocrit goes up. Classical example is, yes, burns. If there are extensive burns on the body, from the burnt tissues, you know, a lot of plasma exude out, because in burnt tissue there is severe thermal injury and nearby capillaries have severe interendothelial gaps formation. There is too much endothelial damage and capillaries start oozing out not simple fluid but a lot of plasma outward. So, patient who are having extensive burns, lot of plasma fluid oozes out of cardiovascular system into burnt tissue, right, and effective volume has been reduced in cardiovascular system, right. Then there is another condition I am not expecting you to know, but if you know it I will be pleasantly surprised. There is another condition, skin condition, in which there is a very severe inflammation of the skin and a lot of you can say plasma is lost into skin layers, right, and cardiovascular system become deficient in volume. So, can you tell me the condition? Okay, before you tell me something totally new, that condition is called exfoliative dermatitis. Exfoliative dermatitis, right. Now, next thing which can be lost from cardiovascular system is, look, in category A we were talking about the whole blood was lost. In category B we were talking about the plasma loss, right. In category C of hypovolemia we will be now discussing loss of fluids and electrolytes. Loss of fluids and electrolytes out of circulatory system, right. Lot of fluids and electrolyte. I think the simplest examples are, for example, in severe diarrhea. Of course, if person is losing too much fluid in diarrhea, how you define diarrhea? I know everyone knows diarrhea. How do you really medically define diarrhea? Okay, how much daily fecal matter you are allowed to produce? What I really mean that if fecal matter is more than that, we'll say you have diarrhea. Because if fecal amount is more than that, then either you can say frequency of the defecation will increase and fluidity of the content will increase. So how much normally you should produce? It is about, usually it's around 200 ml, and if it is, and if 250 ml or around that, if you are more than that, we say you are having diarrhea. Is that right? Now, anyway, someone is losing too much fluid, for example in cholera, person is losing too much fluid, and when he tries to drink the water, he will vomit out, right? Even you can say diarrhea and vomiting. Okay, diarrhea and vomiting. Right? Without fluid replacement will lead to severe losses of volume. So this may be diarrhea, GIT losses, or there may be vomiting, again GIT losses, right? Or polyuria, hyperosmolar conditions. In hyperosmolar conditions, there is heavy loss of volume in the urine, right? There may be polyuria without replacement of the fluids. So patient has diarrhea, or he has vomiting, or he has polyuria. Is that right? And this type of situation is especially seen in diabetic ketoacidosis, DKA. Have you heard of DKA? Diabetic ketoacidosis. Again, we will discuss that topic in medicine. Very important. If you really know the arrangements in DKA and you are capable of correcting it, you are capable of saving the life. Right? So hyperosmolar conditions like diabetic ketoacidosis or polyuria due to any reason. And then of course, if you are lost in the desert, hot, burning, blazing sun, and you are not having enough water, that may lead to severe dehydration also. So you can say excessive, yes, sweating. Excessive sweating without fluid replacements, right? This can also lead to fluid and electrolyte losses, right? So these fluid and electrolyte losses which I have discussed here, these are external losses. These fluid and electrolyte losses are external losses. These are the external losses. Then fluid and electrolyte balance, or you can say fluid may be lost internally. There may be internal losses. Internal losses are actually called third spacing. Internal losses, that within your body fluid and electrolytes are lost. Rather, fluid and electrolytes in massive amounts are trapped within your body, and if they are trapped, of course they are lost from circulatory system. The classical example of this situation is ascites or bowel obstruction. This may be ascites or bowel GIT obstruction, or acute pancreatitis. When pancreas becomes severely inflamed, then lot of tissue around it also become inflamed, and lot of fluid is in that inflamed area, lot of fluid is trapped, and some of the fluid is you can say accumulated into smaller sac or bigger sac. Is that right? So in pancreatitis also lot of fluid is trapped. Pancreatitis, of course acute pancreatitis, not chronic. That may lead to formation of pseudocyst within abdomen. Have you heard of this term? And you know, pancreatitis is managed on medical floors or surgical floors. This is a medical condition which should be managed on surgical floors, because acute pancreatitis may mix like surgical emergency. Usually they get admitted into surgical side, and if serious complications develop, then you may need to do surgery, right? So that is why about pancreatitis, severe acute pancreatitis, you can write it down. It's a medical condition which is usually managed in surgical floors, right? So these were some important causes of hypovolemic shock. What we learn here, in category A, we were losing the whole blood. In category B, we were losing just plasma. In category C, just a part of a plasma, fluid and electrolyte, which may be lost externally or internally. Now we will be discussing the main causes of cardiogenic shock. Cardiogenic shock. Cardiogenic shock. Now, as I told you, in cardiogenic shock, the main problem is that the heart is unable to produce enough cardiac output. Problem is not with the volume or the capacity. Now, we have to see that why heart is unable to produce enough cardiac output, right? What could be the reason? One reason could be like arrhythmias. Cardiogenic shock, one causes are arrhythmias. And here the point which you have to remember is that arrhythmias, they are bradyarrhythmias or tachyarrhythmias, both can lead to cardiogenic shock. I will explain how. Arrhythmias which may be tachyarrhythmias, as well as severe bradyarrhythmias. Now, the question is that how tachyarrhythmia will lead to shock. For example, we talk about ventricular fibrillation. First, I have to make a very important concept clear. When heart rate increases, usually we say cardiac output is equal to heart rate into stroke volume. Is that right? Now, normally when heart rate is increasing, cardiac output is increasing. But when heart rate goes beyond a certain limit, start going beyond a certain limit, cardiac output decreasing. Why? Because then stroke volume is dangerously going down. Now, question is that when heart rate becomes really very high, why stroke volume dangerously is reducing? Answer is when heart rate becomes very fast, then naturally cardiac cycle time is reduced. For example, if I tell you that your heart rate is 220, is that right? Then how your cardiac output will be less? Let me explain. For example, your heart is beating at the rate of 72 beats per minute. Under these circumstances, one cardiac cycle time is 0.8 second. Out of this 0.8 second, 0.3 second is for systole and 0.5 second is for diastole. Is it clear? Now it is when your heart rate is supposed 72 and your cardiac cycle time is 0.8 second. Now you imagine your heart rate becomes 3 times more. For example, your heart rate is 216. If your heart rate is 216, ventricular beating is 216, it means cardiac cycle duration is 1/3. Cardiac cycle duration will become 1/3. It is no more 0.8 second. How much it will become? 0.2 6 seconds, for example. Now you see, cardiac cycle duration has been reduced significantly at very heart rate. But out of this, the point which you have to remember is that major changes that systole out of 0.3 second may be now 0.2 second, and diastole which was 0.5 second may be 0.06 second. Now what did we learn? That when heart rate goes rapidly increasing, it is not the systolic time which rapidly reduces, but really reduces is diastolic time. Diastolic time is the ventricular filling time. Diastolic time is ventricular filling time. So what really happens, again let me explain, that in the patients when heart rate start going up, right, beyond a certain limit, for example around 180 beats per minute, diastole starts shrinking rapidly, and diastolic time becomes so less that ventricle cannot fill. If ventricle filling times are dangerously reduced, can we maintain the stroke volume? So even if heart rate is very high, stroke volume is too low, and when stroke volume is too low, cardiac output drops. Now let me give you an example, that let's suppose if I say your heart rate is very fast, it is 200 and stroke volume is only 10. Then total cardiac output is 2000. But normally you have 72 heart rate and about 70 ml is stroke volume, and it becomes 5000 ml, or you can say 5 liter. Now it means person with 72 beats per minute and stroke volume of 70 is having cardiac output of 5 liter. But the same person, when heart rate goes very fast, right, heart rate has gone very fast like 200, and stroke volume has dangerously dropped from 70 to 10, then increase in the heart rate is not as much, there is a dangerous precipitous fall in the stroke volume. So in the end, cardiac output is dangerously low, and this person will go into cardiogenic shock. So from today onward, you have to remember one thing, when heart rate start increasing, initially heart rate is increasing, but stroke volume is not significantly affected. So cardiac output keep on increasing. But when heart rate becomes so fast, that diastolic time becomes so less, that ventricular filling is dangerously impaired and stroke volume dangerously start falling, then naturally further increase in the heart rate will be associated with decreasing cardiac output, not increasing cardiac output. And if heart rate is really too fast, then heart will not pump well and you will end up with cardiogenic shock. The classical example here I would like to give is ventricular arrhythmias. You know, in ventricular arrhythmia, what is the cardiac output? Answer is 0. Because when especially ventricular, fibrillation, corrected, in case of ventricular fibrillation, right? In case of ventricular fibrillation, electrical activity of ventricle may be 400, right, per minute. But heart is beating electrically so fast that mechanically heart cannot work and cardiac output drop to 0. So in ventricular fibrillation, patient may be pulseless and BP less. So when patient becomes pulseless and BP less, of course, if you don't defibrillate him rapidly, he is going to die. So what I am going to say, that again let me repeat it, that tachyarrhythmias can produce cardiogenic shock, but you have to remember that slight tachycardias actually increases cardiac output. But when tachycardia becomes very fast and diastolic time rapidly reduces and you undergo cardiogenic shock. Is that clear? Now we come to bradyarrhythmia. It's easy to understand. The severe bradyarrhythmia, why they will take to the, you can say, cardiac failure or cardiogenic shock. Again, let me repeat it. The cardiac output is equal to heart rate into stroke volume. Is that right? Now, cardiac output, if someone has heart rate of only 10, and even if stroke volume is normal like 70, 700 ml is extremely low cardiac output. Normally cardiac output is around 5000. So this is a calculation which is showing that in severe bradyarrhythmias, in spite of the fact that even if stroke volume is maintained well, you will have dangerously low cardiac output and you will go into what problem? Cardiogenic shock. So, arrhythmias, very severe tachyarrhythmias or very severe bradyarrhythmias, both of them can precipitate cardiogenic shock by reducing the cardiac output dangerously low, right? Then we can come to true pump failure, right? That in the heart, problem is not with the rhythm. This was cardiogenic shock due to rhythm problem. Now we are going to talk about cardiogenic shock which is truly due to pump failure. Pump failure, right? The classical example of this is massive myocardial infarction. Massive myocardial infarction. Massive myocardial infarction. When there is massive myocardial infarction, let's suppose this much area of the myocardium is infarcted, right? And it is not contracting. Can heart maintain cardiac output? Because stroke volume will be dangerously low, and again patient will go into cardiogenic shock, right? Pump failure may be massive myocardial infarction. Sometimes pump failure may be due to severe type of cardiomyopathies. Cardiomyopathies. For example, dilating cardiomyopathy. In dilating cardiomyopathy, what really happens that myocardium is, left ventricle is dangerously dilated, and if left ventricle is too much dilated, right, then it cannot maintain the cardiac output. Let me explain why. If left ventricle is too much dilated, is that right? Now, why cardiac output cannot be maintained? Because the pressure which is generated, to push the blood out, the pressure which is generated to produce a stroke volume, right, is equal to roughly tension by radius. I have omitted some part of the equation, but pressure is directly proportional to the tension in the wall, the tension which is produced in the wall, and the radius. Now, what really happens that in a very much dilated heart, right, that whatever tension heart can produce, because radius is too big, so it cannot produce the pressure. Let me tell you one simple example, that let's suppose normal heart is producing pressure of 120 or pressure of 100 millimeter of mercury, right, and radius is 5 centimeters square, right, and maybe then tension is how much? It is 500 units. So 500 units of tension divided by 5 centimeter is 100 unit of pressure. Now you imagine that tension is same, but it has dilated, and if it has dilated, now it is supposed 10 centimeter. If it is 10 centimeter, the pressure generated are very, very less. These pressures are not enough to maintain enough cardiac output, and that will translate into what? That will translate into cardiogenic shock. So what I am trying to explain here, that there may be severe rhythm problems, tachyarrhythmia severe or bradyarrhythmia severe, both will end up into cardiogenic shock. Or there is pump problem, either there is very much dilated heart, or there is non-kinetic, you can say hypokinetic heart. Hypokinetic heart means heart is not contracting well. For example, in massive MI, you will end up with the cardiogenic shock. Then another condition is, which can lead to cardiogenic shock, is severe valvular failure. Severe valvular, for example, regurgitation. Severe valvular dysfunction, especially regurgitation. Severe valvular dysfunction. For example, we talk about valvular regurgitation. Again, one of the simple example, that if there is valve become acutely regurgitant, if valve becomes acutely regurgitant, right, cardiac output cannot be maintained. Let's talk about mitral valve. That here is mitral valve, and here are chorda tendineae, and here are muscle papillary muscles. Now what really happens, that if there is, and suppose if there is infective endocarditis here, and infective vegetation destroy the valve, there will be very severe regurgitation. So whenever left ventricle will contract, right, rather than producing stroke volume towards the aorta, lot of blood will be regurgitating in reverse direction into atrium, right? Number one. Number two, or another example is that let's suppose there is rupture of papillary muscle. In some patient with myocardial infarction, if papillary muscle is also damaged, there may be rupture of papillary muscle. And if there is rupture of papillary muscle, right, then papillary muscle of course lose their function, and whenever left ventricle contract, it will be leading to very strong regurgitant current to the atrium. So it cannot maintain its stroke volume and cardiac output, and that may lead to cardiogenic shock. So cardiogenic shock can be produced by very severe valvular lesion like mitral valve regurgitation or aortic valve regurgitation. Regurgitating lesions are more prone to produce cardiogenic shock than the stenotic lesions. Then one of the very simple example, cardiogenic shock, when there is rupture of free wall of the left ventricle or when there is rupture of cardiac septum. Let's suppose here is your heart and this area is infarcted. This area is infarcted. Of course, here is your pericardium. Now, what really happens that on around the third day of the myocardial infarction, lot of neutrophils and macrophages are active within the infarcted tissue, and sometimes these neutrophils and macrophages produce so much proteolytic and destructive enzymes that myocardial tissue may be very weak, and during a strong systole it may rupture. And if it ruptures, it will throw a lot of blood into which cavity? Pericardial cavity, right? And of course, it is no more a effective pump. And the blood which is coming into pericardial cavity, right, you can say there will be hemopericardium, and this pericardium, when it becomes full, it will squeeze the heart and heart will lose its function and you will go into severe cardiogenic failure. Is that right? Or yes, septum. In some infarction, septum is also involved, and if septal wall ruptures, whenever left ventricle will produce the tension to produce the pressure, lot of, you can say, blood will be, effort of the left ventricle will be lost as blood is moving from left to right. Am I clear? So we can say that rupture of ventricular septum or the free wall, rupture of ventricular septum or free wall, that will also lead to failure of the ventricle to work, right? That may lead to cardiogenic shock. Now we come to distributive shock. We have already discussed some component of distributive shock, that we discussed that in distributive shock what really happens is that there is pathological and massive dilatation of vascular system, and when vascular system is dilated too much, right, blood is pathologically distributed in the body. Let me write here distributive shock. Now, in distributive shock, what really happens? In distributive shock, what really happens? We have already discussed that blood volume is 5 liter, but in distributive shock, capacity is dangerously increased, right? And if vascular system dilate too much, you know, normally capacity is how much? Normally 5 liters, and volume is how much? 5 liters. But if capacity becomes 15 liter, if capacity becomes too much, blood will be pooled in the periphery. Will the blood properly return to the heart to be pumped? No, and that will lead to failure of heart function. But we don't call it cardiogenic shock because primary problem is not with the heart. Primary problem is not with the heart. We cannot blame the pump if we don't supply the pump with the fluid. We have to blame the capacity of the peripheral circulatory system. In particular cases, we have already discussed septic shock. Okay, let me explain. Under what circumstances you may have Now, here is your vasomotor center, right? Then these are the pathways which are coming down, and from here, sympathetic neurons are going preganglionic sympathetic, right? And then there are postganglionic sympathetic fibers. Now, anything which lead to massive vasodilatation, which will lead to what type of shock? Distributive shock. Now, let's look at what could be the conditions of such type of shock. One cause of this is neurogenic shock. Neurogenic shock. When we say there's neurogenic shock, it means something wrong with the nervous system, and you know, one of the major function of the autonomic nervous system is, especially sympathetic nervous system, is to maintain the tone in vasculature. In a normal person, arterioles and veins are semi-constricted. Now, if there is a major sympathetic outflow problem, if due to any reason, if sympathetic nervous system is not working, arteries and veins will pathologically dilate and there will be peripheral pooling. Now, what could be the causes of neurogenic shock? Number one, cause of neurogenic shock may be vasomotor center failure or vasomotor center depression. If you are taking some drugs which are CNS depressant, someone has toxicity of those drugs, that will lead to vasomotor center failure, right? Or there may be, suppose, medullary infarctions or medullary tumors in the medulla, and they may damage the vasomotor center. Or someone has spinal cord damage. The spinal cord is severely damaged. Do you think there can be good sympathetic outflow? No. And if sympathetic outflow fail, again a lot of vessels dilate and peripheral pooling of the blood occur. Or you have given, so this is second. Number one was problem in the medulla. Central sympathetic outflow fails. Second cause is spinal cord outflow is problem. We also call it spinal shock. Spinal shock. Then third is ganglion blocker. If you give very big high dose of ganglion blocker to someone, patient will go into shock. Then nerve ending blockers, sympatholytic drugs. You know, sympatholytic drugs toxicity always lead to very severe problem. It may be central sympatholytic, it may be ganglion blockers, and here is the mechanism, the drugs which block the release of norepinephrine. Or the fifth mechanism may be the drugs which, toxicity of the drug which block the alpha-1 receptors. For example, someone has taken toxic doses of prazosin or trazocin, which alpha-1 blocker, that may lead to the trouble, right? Or anyone who has any other vasodilator drug toxicity, for example, hydralazine. If someone has taken, you can say, toxic doses of hydralazine or toxic doses of minoxidil or toxic doses of any other vasodilator, naturally all the vasculature will be dilated, and that may lead to failure of distribution system. That whole the distribution system will be pathological, blood will be pooled in the periphery and it is not returning. So under all these circumstances, and other group of problem is, I have already told you that in the perivascular connective tissue there are a lot of mast cells. In the perivascular connective tissue there are a lot of mast cells which are loaded with which antibody? IgE. And if allergic substance enters in your body, if you have made an IgE against a particular substance, right, or particular drug, and your mast cells are preloaded, if your mast cells are already loaded with IgE, then what really happens? That allergic substance will come, stimulate the IgE, IgE will stimulate the mast cell, and mast cell will release massive amount of, yes, vasodilators like histamine, and again there will be shock. And this type of shock is called not neurogenic shock. This type of distributive shock is anaphylactic shock. Then another cause of distributive shock is septicemias. We have already discussed that in case of septic shock, this is also called warm shock because peripheral vessels are not constricted, they are rather pathologically dilated. In septic shock, what really happens, a lot of bacteria are there, or there are a lot of toxins, especially endotoxins, which stimulate the endothelial cells, stimulate the white blood cells, and a lot of cytokines are produced, and all this culminate into production of a lot of vasodilators, and vessels pathologically dilate, and some fluid also oozes out from the vascular system to the interstitial area because due to increased permeability of microcirculation in septic shock, plus because most of the vessels are too much dilated, so blood is pathologically distributed in the peripheral part and blood cannot return back to the heart. Is that clear? After that we come to, right, so we were talking about distributive shock, which may be septic shock or anaphylactic shock or neurogenic shock or vasodilated drug shock, or one more thing, acute failure of adrenal gland. If there is acute adrenal insufficiency, can you tell me a cause of acute adrenal insufficiency? Can you tell me a cause of acute adrenal insufficiency? Okay, I will give you a hint. In meningococcemia, sometimes both adrenal glands undergo hemorrhagic damage. You don't know that. Pathology is not that good in your mind. Okay, you just trust me, I'm right. That in meningococcal infections, especially septicemia, these meningococci may damage, or toxins released from them may damage the adrenal cortex, and if adrenal cortex is severely damaged and develop hemorrhagic lesions, right, that will produce severe vasodilatation because vasoconstrictor substances are not produced from there, and we say there is acute adrenal insufficiency which lead to the shock. After that we go to the next category of shock. The fourth category we were discussing was, we have already discussed hypovolemic shock and its causes, then we have discussed cardiogenic shock and its causes. After that, right now we discussed distributive shock and its different causes, and now we are left with one, and that is which type of shock? Obstructive shock. Now we are left with obstructive shock. In case of obstructive shock, what was wrong with the patient? That there was some major part to some part of there was some major obstruction, right, to the either luminal obstruction or external compression, right, and that lead to obstructive shock. Let me give you some examples. Obstructive shock. Now what really happens in obstructive shock? Okay, you will understand. One example is cardiac tamponade. What is cardiac tamponade? Have you heard of this word? Cardiac tamponade. What is cardiac tamponade? Yes. This is your heart and this is around it. What is this? Pericardium, right? Now, if there's too much fluid accumulated in pericardium, normally pericardium has clear fluid and small amount, less than 30 ml, far less than 30 ml even. But if you have too much fluid, right, accumulated in pericardium, then heart is into trouble. You know what really happens to heart? Heart becomes something like this. And this is the pathological fluid which is accumulating. Now you see this pathological fluid which is accumulated in pericardium, it is compressing the both ventricles. If it is compressing the both ventricle, can they fill properly? Can the venous blood easily come into right atrium and leave out? No. Even can properly left ventricle can fill and eject out? No. So what we say that in case of pericardial effusions, if pericardial effusion becomes so much if pericardial effusion becomes so much that it start compromising the ventricular filling, right? Then patient will have rising JVP because right heart is not accepting the venous return. So patient will have rising JVP. Number 2, patient will have falling systemic blood pressure. Look, when right heart is compressed, jugular venous pressure will go up. When left heart is compressed, then systemic blood pressure cannot be maintained. So such patients which have massive pericardial effusion, if they start developing rising JVP, rising jugular venous pressure, falling, yes, blood pressure, and distant heart sound, distant heart sound. The condition is called cardiac tamponade. Tamponates. So every pericardial effusion is not cardiac tamponade. Every pericardial effusion is not cardiac tamponade. Cardiac tamponade is said to be present when pericardial effusion is so much that it is compromising the ventricular filling or obstructing the ventricular flow, right, and leading to progressively rising JVP, falling blood pressure, and distant heart sound, because when you will try to hear it, you cannot hear well because there is a lot of pericardial effusion. So cardiac tamponade is a condition in which cardiovascular system is compressed or heart is compressed so much that its flow is obstructed. Is that clear? And when flow is obstructive, then we say there is obstructive shock. So one of the example of obstructive shock is cardiac tamponade. Tamponade. Right? One of the cause of obstructive shock is cardiac tamponade. Then another cause is tension pneumothorax. Tension pneumothorax. What is this tension pneumothorax? Who will tell me? What really happens in a patient with tension pneumothorax? Are you going to explain it to me? Yes, air, where? In the pleural cavity. Let's suppose someone for example, someone get a stab injury here, knife stab here, and a flap like entry of the air forms from the atmosphere to the pleural cavity. With every inspiration, if patient is taking the air in, but during expiration he is not throwing the air out, then what will really happen? That in this person, that air is progressively entering, air is filling up the pleural cavity. And why we call it tension pneumothorax, mean air in the pleural cavity. And why we call it tension? Because air is under tension, that during inspiration it enters, but during expiration it cannot come out. And because it is progressively accumulating, so lungs will be collapsed, and even lung may be pushed to the opposite side. And here is your cable system. Now listen carefully, that if air keep on accumulating here, right, look here, if lungs are progressively being pushed to the opposite side, that will produce the major kinking, bend or kinking in the major venous flow. Can blood flow properly to the heart? No, and that will lead to obstructive shock. So in tension pneumothorax, again let me repeat it, what really happens in tension pneumothorax, there is some lesion which is acting like a valve, and during inspiration air enters into pleural cavity, but during expiration air cannot get out. So air is progressively accumulated in pleural cavity. When air is accumulated progressively under tension, it keep on pressing the lungs, and lungs, when they are being pushed from the air in the pleural cavity towards the mediastinum, right, mediastinum is displaced, and major venous input system to the heart, that is superior vena cava and inferior vena cava, they are bent or kinked too much, and you can say cardiovascular flow cannot be maintained from the venous side to the right heart, and that may lead to what type of problem? Obstructive shock. So there can be tension pneumothorax, there can be pericardial disease like tamponade. Then of course we should not forget one classical example of obstructive shock, that is massive pulmonary. This has to be massive. There is massive pulmonary embolism. Embolism. The classical example of this, when there is massive pulmonary embolism, is, suppose this is the right heart and this is the pulmonary artery outflow. Now listen, if a big, from the leg, let's suppose from the leg a big thrombus is moving from here, and if it gets stuck over here, you know, from deep venous thrombosis, DVT, right, from the deep veins of the leg, a big thrombus moves and passes through the heart, and then it is stuck with the major pulmonary tree. Now, heart cannot, it is producing so much obstruction that right heart cannot maintain the cardiac output, right, and there is major obstruction to the cardiovascular flow system. So we call it again that this is one more example of obstructive shock. This is one more example of obstructive shock. Then, okay, one more cause of obstructive shock. You will tell me something, what is this? There is a tumor here. This tumor usually forms in the left atrium, and in some patients it may block, right? And if this tumor, which is usually originating within the left atrium, if it blocks the mitral valve, there will be severe obstruction to the cardiovascular flow system. Can you tell me the name of the tumor? You must have heard of it. Yes. Who will tell me the name of the tumor? And when I will tell you, you will say you have heard of it. You have heard of atrial myxoma? Or never heard? Atrial myxoma, right? There will be obstruction sometimes, not in all patients of atrial myxoma, but in some patients with atrial myxoma, there may be severe obstruction, and that severe obstruction may lead to obstructive problem, right? Then in the same way, there may be left atrial mural thrombus. If a very big mural thrombus is formed here, and this thrombus may block, is that right? Left atrial mural thrombus, is that right? Left atrial mural thrombus, right? So after that, we have completed now the common causes of shock, right? Before I really finish the causes, I would like to introduce a very unusual type of situation in which there is syncope. You know how you define syncope? Syncope, syncope. Yeah, it is transient loss of consciousness due to generalized hypoxia to the cerebral cortex. This is transient loss of, yes, transient loss of consciousness due to global hypoxia to the, yes, cerebral cortex. Now, why syncope occurs sometimes? Some people think it's shock, right? Actually, it is usually vasovagal situation, that in some patients suddenly, right, due to fear or due to prolonged standing, or sometimes even during micturition or during severe bout of cough, right, or right, they develop severe, you can say, activity of parasympathetic nervous system and the severe vagal activity. And if that vagal activity leads to inhibition of heart for few seconds and dilatation of a lot of vessels, So both things are combined. There's low cardiac output with vasodilatory system, and they become naturally, then cardiovascular system cannot maintain the blood flow to the cerebral cortex, and they become transiently unconscious. Is that right? Okay, let's have a break, and then we will go to the stages of shock. Now we will talk about the different stages of shock. Stages of shock. Now when we talk about the stages of shock, this is, let's suppose that you have a patient. Some patient with the shock die very soon, but most of the patient, if they are not treated well, then they keep on deteriorating progressively. But what really happens, that in the first stage, biological system is, you see, biological injury is going on, and within the body there are mechanisms which will compensate and support it. The mechanisms which will prevent the deterioration and support it. But if these mechanisms, at this stage, where different biological mechanisms, right, they are activated in our body, compensatory mechanisms, and they are trying to support the cardiovascular system, right, this stage is called non-progressive compensated stage. Compensated non-progressive stage. Some people also call it non-progressive compensated stage of shock. What really happens in this stage is, again listen carefully, that for example this person got an injury. To explain these stages of shock, we are taking an example that there is a roadside accident. You reach there, you pick up a patient, and you put the patient in your car, and now you are taking the patient to hospital. On the way, patient is bleeding, right? Suppose internally, right? There is some internal injury also, and person is bleeding. You are unable to stop the bleeding. Now, initially, when bleeding is, he is losing the volume and shock has started, there are some biological mechanisms which I will discuss into detail. They will try to help the cardiovascular system to stabilize, and patient is, even though passing through a stage of shock, but he is not deteriorating rapidly. So we say shock is there, but it is not progressing to deterioration. So we call it non-progressive shock, not progressing to deterioration. Then if, for example, on the way, if you have not reached to hospital in time, right, then compensatory mechanisms start failing. And when compensatory mechanisms start failing, now you see what is happening. It is next phase of shock. What is happening here? Patient is progressing towards more deteriorated stage, and this stage is called progressive stage of shock. That is called progressive stage of shock. Progressive stage of shock. During this, if you reach hospital and provide him appropriate care, right, appropriate care, proper fluids, right, and in this case patient can be reversed, right, and patient will come out of shock, cardiovascular system will become stable. But somewhere, I will explain later why, somewhere here patient may go, now very rapidly patient is deteriorating, right, and in this case we call it that this is refractory shock, this is called refractory shock, or this is called irreversible shock. This is called refractory shock or irreversible shock. Refractory, because it is refractory to treatment, refractory shock, or more commonly it is called irreversible stage of shock. Irreversible stage. Now again listen. If a person who is bleeding with moderate speed internally, right, and his biological system has to fight against the deterioration, but of course biological system cannot fight forever. Again I'm repeating the information. If there is roadside accident, you took up one patient in your car, you're taking the patient to hospital. When you are on the way, right, initially his biological system compensatory mechanisms will be activated in his body to stabilize the cardiovascular system, and after that if you still not provided the proper treatment, then it will start progressively deteriorating the patient, but still during this phase if you go to the hospital, get the proper treatment, patient will recover. But if still patient does not get the treatment, eventually he will enter into a stage of shock in which situation become refractory, resistant to treatment, or even irreversible, and then even you bring the best treatment in the world, you cannot save the patient. Now we will discuss one by one different stages of shock. First of all, we will discuss into detail non-progressive compensated stage. Right? Now we are going to talk about non-progressive compensated stage. Now when we talk about non-progressive compensated stage, let's suppose this is a circulatory system of the patient. This is a circulatory system of the patient. Here is the patient or injured patient's central nervous system. Now what really happens? Number one, bleeding is going on here. Patient is losing the blood. Right? That is the problem. Hemorrhage. Blood is being lost. Now how the compensatory mechanisms will be activated? That is what we have to understand. Right? Number one, you know that in the cardiovascular system, there are carotid bodies and aortic bodies which have chemoreceptors. Plus there are carotid sinus which has baroreceptor. First, as soon as blood pressure will fall, as soon as blood volume is lost, what will happen? Venous return will be decreased. When venous return to the heart is decreased, naturally cardiac output is decreased. When cardiac output is decreased, then carotid sinus is less stretched. Right? You know, carotid sinus has baroreceptors which keep on measuring the blood pressure. So again, bleeding is started, venous return to heart is decreased, cardiac filling is less, cardiac output is less, blood pressure is dropping. Now this slight drop in the blood pressure is sensed by nerve endings in carotid sinus. Now these nerve endings from the carotid sinus, let's suppose these are the nerve endings from the carotid sinus, right? They will report this information to the central nervous system, to medulla. The blood pressure is falling, right? Actually, listen carefully. What really happens that when your blood pressure is high, baroreceptor nerve endings are more stretched, right? When your blood pressure is high, baroreceptor nerve endings are more stretched and they produce more action potential. And if they produce more action potential in high blood pressure, they keep the vasomotor center suppressed. But during the shock, reverse happens. What happens during the shock? Blood pressure is falling. Fall in blood pressure. Fall in blood pressure, reduced stretch of baroreceptor nerve endings. Then reduced action potentials. Reduced suppression of, there is reduced suppression of vasomotor center. There is reduced suppression of vasomotor center. So vasomotor center will fire. When vasomotor center will fire, now you know that sympathetic outflow will occur to thoracolumbar area. Now sympathetic neurons right? Some of these sympathetic neurons, they are going to heart, right? Some of these sympathetic neurons, of course, through the sympathetic ganglion, they are going to veins. Some of these sympathetic neurons, they are going to supply the smooth muscles on arterial side, right? Some of these sympathetic fibers, they will be going to the kidney and juxtaglomerular, they will stimulate juxtaglomerular apparatus in kidney. Some of these will stimulate adrenal medulla. Now what really happens? That from these nerve endings, the release of norepinephrine on cardiac tissue, norepinephrine on venous smooth muscles, norepinephrine on arterial smooth muscle, and when juxtaglomerular apparatus is activated, this will release renin, right? In the same way, sympathetic nervous system also stimulates juxtaglomerular apparatus because juxtaglomerular apparatus has beta-1 adrenergic receptors. Plus, it will stimulate the adrenal medulla, and from the adrenal medulla, there is release of, what is the release of? Epinephrine. There is release of epinephrine. So it means that what really happens to this patient, that his sympathetic nervous system is activated, right? Again, let me repeat. What is happening to this person? His sympathetic nervous system is one of the early compensatory mechanisms which are activated. Why sympathetic nervous system is activated? There are multiple factors. Number one, baroreceptor reports that blood pressure is falling, so sympathetic nervous system is activated. Number two, horror of the accident produces anxiety and fear, that activates the sympathetic nervous system, right? Then if patients see the severe pain will also activate the sympathetic nervous system. Now let me repeat it again. That in a patient who has suffered with the injury from higher psychic center, right, fear and anxiety, right, these factors will stimulate from the limbic system, emotional centers, right, they will activate the sympathetic outflow, vasomotor outflow. Secondly, baroreceptors are reporting blood pressure is falling, vasomotor system is no more inhibited or released from inhibition. Number three, if patient has broken leg or the severe pain, then ascending pathways of the pain, on the way they will stimulate the reticular formation and also activate the vasomotor center. So what really happens, that psychic fear, pain, baroreceptor activity, all of this is stimulating sympathetic nervous system. Now it is first biological system which is trying to compensate, trying to stabilize the cardiovascular system. How? Number one, what is happening to the heart? The sympathetic nervous system, when it is firing on the heart, of course, and not only neurons are releasing norepinephrine, rather from the blood, epinephrine is also coming to the heart. Under the influence of sympathetic nervous system, what will happen? Heart rate will, yes, now I'll write here, the sympathetic nervous system is leading to increased heart rate, increased stroke volume. Even though it increases heart rate, which is called positive chronotropic action, it increases conduction through AV node, we call it positive dromotropic action, it increases the automaticity, pathological automaticity in the heart, which is not good for the patient, that is positive bathmotropic action, and of course it increases the contractility of the heart, that is positive inotropic action. So all of these sympathetic activity increase the heart rate, increase the stroke volume, and both of these things increase the cardiac output. Both of these things try to increase the cardiac output. This is number one thing. Number two thing, that sympathetic nervous system will lead to venoconstriction. Sympathetic nervous system is leading to, yes, venoconstriction. And when there is venoconstriction, when look here, when veins will constrict, a lot of blood is normally pooled in veins. About 70% of the blood in the body is on the venous side. So when sympathetic nervous system will stimulate the veins, venomotor tone will increase. When veins will constrict, they will squeeze the blood to heart. When they will squeeze the blood to the heart, cardiac filling will increase, preload will increase, end diastolic volume will increase, Frank-Starling law will be operative. Again, veins will constrict, push more blood towards the heart, right? Cardiac filling is increased, and Frank Starling law says more you put in the heart, more it stroke volume is there. So increased venous return will increase end-diastolic volume, and that will be again associated with increasing cardiac output. So now you can come to venoconstriction, which is leading to increased preload, and when heart has increased preload, that will lead to increased cardiac output, right? And it means the cardiac output is increased by direct stimulation of heart by sympathetic nervous system, and cardiac output is increased by venomotor stimulation, and of course, you know, blood pressure, systolic blood pressure depends on cardiac output, and diastolic blood pressure depend on systolic blood pressure depend on cardiac output, and diastolic blood pressure mainly depends on total peripheral resistance. So what really happened up to now, that cardiostimulation and venostimulation has increased cardiac output. It means these two systems have led to stabilization of systolic blood pressure. What has happened? These two mechanisms have stabilized the systolic blood pressure. Is that right? Now, next what is happening? There is arterioconstriction. Sympathetic nervous system and epinephrine and norepinephrine will produce arterioconstriction. When arterioles are constricted, total peripheral resistance is increased. Again, arterioconstriction will lead to, yes, increased total peripheral resistance, and increased total peripheral resistance will lead to increased diastolic blood pressure. So in short, we can say sympathetic overflow by stimulating the venoconstriction and increasing cardiac output, and directly acting on the heart and increasing cardiac output stabilizes the systolic blood pressure, and sympathetic nervous system by producing arterioconstriction by increasing the total peripheral resistance stabilizes the diastolic blood pressure. Right? So it means normally when you are going through bleeding process, your blood pressure tend to fall. Blood pressure has a tendency to fall, but these compensatory mechanisms are trying to stabilize the systolic and diastolic blood pressure. Now, this is not the only sympathetic activity. There are more activities also, more compensatory mechanisms. And what are those mechanisms? The other mechanism is, one we say sympathetic overflow, sympathetic adrenergic system. Number two, there is activation of renin, angiotensin, aldosterone axis. Now, how it is really stimulated? This is your renal system, and naturally blood flow to kidneys decreased, there is reduced perfusion. One more thing which I should have explained, and now I am going to explain. Sympathetic nervous system is doing one very wonderful thing, which I have not mentioned. Can you tell me? Sympathetic nervous system in a patient who is undergoing shock does one extremely wonderful thing for the patient, which I have not mentioned. So can you tell me? Okay, let me tell you. The next thing which sympathetic nervous system does is that sympathetic nervous system redistributes the blood from different vascular beds. For example, that blood vessels to GIT will constrict, right? Blood vessels to kidney will constrict, blood vessels to even most skin will constrict. So what really happens in these patients, these blood vessels will constrict, cutaneous blood vessels, splanchnic blood vessels will also constrict, even renal blood vessels will also constrict. So actually most of the blood vessels will constrict under these circumstances. What these blood vessels are doing, these vascular beds will constrict so that blood flow to GIT or to the skin or to liver or other tissues which are not helping in this emergency, blood flow to those tissues should be reduced, so that the blood which is pushed to the central circulation, that should be redistributed to more vital organs, that is heart and the brain, because sympathetic nervous system does not lead to any significant constriction of cerebral circulation or coronary circulation. I've told you previously that cerebral vasculature and coronary vasculature is not under the mercy of sympathetic fluctuations. So most of the vascular beds in the body will constrict and the blood will be redistributed in the body, and this blood which is saved from other organs is preferentially supplied to the central nervous system and to the heart. Is that clear? Now, next point which is important is that renin, angiotensin, aldosterone axis is stimulated. Now, why this axis is stimulated? Why there is more renin release? Why there is more renin release? There are two reasons here. Number one, because there is bleeding going on and sympathetic nervous system is activated, renal vessels are constricted. So blood flow to kidney is reduced. In patient with a shock, blood flow to kidney is reduced. Number one, due to decreasing blood pressure. Number two, due to compensatory mechanisms which are activated. They produce intense vasoconstriction of renal vasculature. When there is intense vasoconstriction of renal vasculature, that leads to what problem? Release of renin, right? So reduced renal perfusion will activate the release of renin. And you know, renin, once it is released from the liver, the substance is coming which is called angiotensinogen. So renin will act on angiotensinogen, and when angiotensinogen will pass from pulmonary circulation, angiotensinogen, first of all, listen again, renin will come out, right, under sympathetic stimulation as well as due to hypoperfusion, and this renin will convert angiotensinogen into angiotensin 1, right. So what is the main function of the renin? It will convert angiotensinogen into angiotensin 1. Angiotensin 1 will pass through pulmonary circulation, and endothelial cells of pulmonary vasculature have an enzyme which is called angiotensin converting enzyme, which will convert angiotensin 1 into angiotensin 2. Angiotensin 2. Now angiotensin 2 will do multiple functions. What are the functions? Number one, angiotensin 2 has receptors in the central nervous system. Near the hypothalamus, there is an area called subfornical area. Subfornical area in central nervous system. When this area is stimulated by angiotensin 2, patient will feel thirst. So thirst is a compensatory mechanism, so that patient should drink water. That is why if patient is conscious, and of course at this stage if patient is really conscious, he will ask for water. Patient will feel more thirsty. Number two, angiotensin 2 will act on smooth muscles of veins as well as arterioles. Naturally, there will be venoconstriction and yes, arterioconstriction. You know, venoconstriction increases venous return to the heart, and venous return to the heart will lead to increase end diastolic volume, that will increase cardiac output, and that will lead to increase again stabilization of systolic blood pressure. So it means this is another support for the systolic blood pressure. Secondly, arterioconstriction, right, that will lead to what? Increased arterioconstriction will lead to increased total peripheral resistance, and increased total peripheral resistance will increase diastolic blood pressure. So what really happens that here angiotensin 2, by producing the venoconstriction and increasing the cardiac output, right, stabilizes the systolic blood pressure, and angiotensin 2 by arterioconstriction increasing the total peripheral resistance stabilizes the diastolic blood pressure. So again there is another support to stabilize the patient's systolic and diastolic blood pressure. Plus angiotensin 2 is doing one more function, and what is that function? Angiotensin 2 will act on adrenal cortex. You know, adrenal cortex has zona glomerulosa. It has, this is zona glomerulosa, which has receptors for angiotensin 2. And under the influence of zona glomerulosa, right, under the influence of angiotensin 2, zona glomerulosa will be releasing aldosterone. It will be releasing aldosterone, right. So what is happening, that angiotensin 2, when it acts on adrenal cortex, zona glomerulosa releases aldosterone, and this aldosterone is doing which function? It will lead to salt and water retention. It will act on the nephron, principal cells of the nephron, and principal cells of the nephron start retaining what? Salt and water. This salt and water, what it is doing? The salt and water which is retained, salt plus water, they increase, yes, they increase blood volume. But remember one thing, to activate the aldosterone mediated salt and water retention, it takes more than a half hour, it takes some time, right? Anyway, the blood volume will increase, then what will happen? Venous return will increase, increased venous return will again lead to increase cardiac output and again support for systolic blood pressure. Now you see, there's so many compensatory mechanisms operating in the patient. Patient is refusing to die. Biological system is trying to live, trying to stabilize its blood pressure, right? Sympathetic nervous system has been activated. Number 1, number 2, renin, angiotensin, aldosterone axis has been activated. What 3 major things sympathetic nervous system did was direct action on the heart and increase cardiac output, and venoconstriction and increase cardiac output. And when cardiac output is increased, sympathetic nervous system stabilizes systolic blood pressure. Then I said sympathetic nervous system do arterioconstriction, and that arterioconstriction increase total peripheral resistance, and that again leads to what type of thing? Increased diastolic blood pressure. Then renin, angiotensin, aldosterone axis. How the system is stimulated? Number 1, by sympathetic overflow, beta 1 receptor on the beta 1 receptors on the juxtaglomerular apparatus and release of renin. Number 2, when hypoperfusion of the kidney, again release of renin. And what is happening? That this renin convert angiotensin into angiotensin 1, and which in the lungs get converted into angiotensin 2. Angiotensin 2 can produce thirst. Angiotensin 2 can produce, they have receptor on the smooth muscle of veins as well as arterioles. Venoconstriction, right, that will lead to increased venous return, increased end-diastolic volume, increased cardiac output, again systolic blood pressure stabilization. Number 2, arteriolar smooth muscle stimulated, arterioconstriction, increased total peripheral resistance, again support to the diastolic blood pressure. Moreover, angiotensin 2 stimulates the release of aldosterone from zona glomerulosa. Aldosterone lead to salt and water retention. This retained salt and water lead to increased blood volume, increased venous return, increased cardiac output, again stabilizing the what? Systolic blood pressure, right? Meanwhile, from posterior pituitary, there will be release of ADH. The other name for ADH is vasopressin. So there is a release of ADH. Now, this release of ADH from the posterior pituitary, right, that is serving 2 purposes. Number 1, vasopressin will do arterioconstriction. When vasopressin or ADH in high concentration can stimulate arterioconstriction, total peripheral resistance is increased, and which blood pressure is increased? Diastolic. Systolic blood pressure is on the cardiac output dependent. Diastolic blood pressure is on total peripheral resistance mainly. So ADH will do 2 functions. Number 1, arterioconstriction, which is good for this patient. Number 2, you must be knowing ADH work on the last part of nephron and retain water. And that water which is retained under the influence of ADH, right, that water also increases blood volume, increase venous return, increase cardiac output, again stabilizing systolic blood pressure. So look at the beauty of this. That person is bleeding, loss of blood is trying to destabilize the systolic and diastolic. So look here, it is really like this, that bleeding is trying to take the things down. But these are sympathetic nervous system trying to stabilize it. This is the renin-angiotensin-aldosterone axis trying to stabilize it. This is the ADH release which is trying to stabilize it, right? Then not only these things, there is also central ischemic response. When central nervous system becomes really too ischemic, that again gives another strong burst of sympathetic outflow, right? After that, one more thing which is important is that something called reverse stress relaxation of circulatory system. I will explain what is it. This is one of the compensatory mechanisms. Reverse stress relaxation of circulatory system. Reverse stress relaxation of. Now first you understand this thing, stress relaxation. Attention please. Blood vessels are a very strange type of tubes. If you increase the volume in the blood vessels, right, what they happen, if you increase the blood volume, there is more stress on the wall of the vascular system and vascular system relaxes. And if you decrease the volume, then vascular system shrink. It means blood vessels have some myogenic mechanism. What is that mechanism? Myogenic, not neurogenic. That the smooth muscle tube is such a way that if you put more blood into some vessel, right, lumen, if there is excessive blood, more you stretch, more it contracts. Less you stretch, less it contracts. What does it mean? That when you put the stress by putting extra volume, blood vessels will relax. But when blood is being lost, the mechanism will be reversed. So reversal of the stress relaxation. What does it mean? That volume is lost. For example, there was normally 5 liter volume and there was 5 liter capacity. If 1 liter is lost, then cardiovascular system will reduce its capacity. So cardiovascular system has a strange quality that if volume increases, it slightly increases its capacity. If volume decreases to slight extent, it can decrease its capacity. So by decreasing the capacity of vascular system, right, by reverse stress relaxation, by decreasing the capacity of vascular system, you can say vascular system walls are enveloping around the remaining blood. Is that right? Again, the advantage of that is to prevent the peripheral pooling. To prevent the peripheral pooling, so that blood keep on returning to the heart and cardiac output should be maintained well and blood pressure should not fall. Another attempt by the cardiovascular system to stabilize the blood pressure. Is it clear or should I repeat it? Is it clear to you or not? Not clear? It's okay? Good. Otherwise you can revise the, okay. Next thing. So this is also compensating the loss. The blood was being lost out of the body, and this is a compensatory mechanism. Now how many things are fighting in the patient? These are the fighting to prevent the death. Sympathetic nervous system, renin-angiotensin-aldosterone axis, ADH system, reverse stress, relaxation. Then one more thing occurs which is very interesting. Look, normally what happens? First understand the normal. You see, if we understand any capillary bed, suppose this is a capillary bed in any tissue, this is a tissue and this is a capillary bed. Here is arterial input and here is venous output. Normally what happens? That blood fluid is slightly moving from arterial side of capillary to provide the cells with oxygen and nutrients, and the venous end of the capillaries, fluid is going back. Is that right? So this is what normally happens, that when normal hemodynamics are there, that fluid from the arterial side of capillary is coming out, adding to the interstitial fluid, and this fluid is giving the oxygen and other nutrients to the cells, taking the waste products, and this fluid is going back. Is that right? Now, when person is going under shock, listen carefully. Now fluid here is more or less? There is less. So filtration pressure, filter out pressure is less. and suction pressure is more. So most of the capillary beds lose less fluid to interstitium and get extra fluid from the interstitium, right? Because under the shock situation, in the microcirculation, pressures have dropped. Because in the microcirculation, hydrostatic pressures have dropped, so Starling's forces which are concerned with the microcirculation, they are altered. So rather than that equal output and equal amount of fluid leaving the microcirculation and entering to microcirculation, this is a different situation. Less fluid is leaving the microcirculation and more fluid is taken up by microcirculation, and other attempt by the body to stabilize the blood pressure, right? Of course, this is the interstitial fluid which is being shifted to where? Vascular compartment. Is that right? So microcirculations are sucking the fluid from interstitial area and taking up to the vascular compartment. In the same way, GIT water absorption is also increased. So you can say the shift, fluid shift is occurring to this patient. Fluid shift from interstitial fluid moving towards the vascular fluid. Am I clear? Interstitial fluid is shifting to the vascular fluid, right? So these are some of the compensatory mechanisms which are fighting for the patient and trying to stabilize his blood pressure. Let's suppose you are about 40 kilometers away from the hospital. You have taken the patient from there and you have just come for 20 kilometers. And during these 20 kilometers, person was bleeding. So this bleeding was trying to take it down. But these compensatory mechanisms were trying to stabilize it. So patient does have shock, but this shock is not progressing to deterioration. This shock is well compensated by the biological compensatory mechanism. Am I clear to this stage? Now, let's suppose that you are midway to hospital now, halfway, and there's a traffic jam. Now you are in a trouble. There's a traffic jam, you cannot rush, you are doing pa, pa, poo, poo, pee, pee, but people are not understanding that you are having a patient who is shocked and they should give you away. And of course, you don't have anything like ambulance router or other things, right? Now what happens? For significant time, compensatory mechanism have operated in such a way that there was arterioconstriction to most of the tissues. So most of the tissues were sacrificing their blood flow for the sake of blood flow to heart and to the brain. Is that right? Now around this time, problem will start, right? But before I discuss this stage, I would like, up to now, what were the clinical features? Up to now, patient was having rapid pulse, thready pulse, patient was having cold extremities due to vasoconstriction, patient was having ashen grey color. Is that right? Up to now, patient was looking very, very anxious. Of course, you can understand why. Sympathetic overflow, anxiety, fear. Is that right? This was all during the compensatory stage. In compensatory stage, most of the organs were sacrificing. They had intensely reduced blood flow, and this sacrifice was to provide more and more blood for heart and brain so that vital organs should remain alive. Is that right? And meanwhile, maybe even kidney is at the verge of necrosis, but still it is reducing its blood flow because kidney can make urine later on. It's the time to keep your heart and brain working. Now, you are in the traffic jam. Your car is stuck. Biological compensatory mechanisms are not having unlimited energy. They also start getting exhausted. Now bad things will start happening. I will tell you what bad things will happen. Some very bad things will start happening around this time. Now patient will start deteriorating. Now actually, what is the bad thing? The bad thing is at this moment, you're halfway, you are in the traffic jam, and compensatory mechanisms are now failing. They are exhausted. they are failing. Now tissues are protesting that we have given enough sacrifice to maintain the blood flow for CNS and to the heart. So compensatory mechanisms now not working well, and now deterioration will start. But even if during this stage if you give a good treatment, you can save the patient. But the problem is that you are stuck in the traffic jam. Now while you are in the traffic jam, we see what happens in the patient body, right? Now I told you that patient compensatory mechanisms have done enough sacrifices, many tissue has sacrificed, and now compensatory mechanisms will be blunted and patient will go into progressive stage. What really happens in progressive stage? Let's look at the situation. Number one thing, for a very long time, there have been severe reduction in blood supply to the peripheral tissue. I told you most of the peripheral tissue like GIT, liver, skin and many other tissues, they were having vasoconstriction. So it means for a very long time, this peripheral tissue was having reduced blood flow, right? Naturally, there was reduced oxygen supply. When there was prolonged reduced oxygen supply to the peripheral tissue, naturally the metabolism will alter, that these cells normally in the presence of oxygen, they are capable of breaking the glucose up to pyruvic acid, and then if oxygen is available, pyruvic acid will go into citric acid cycle and convert into lot of ATP. Now, what really happens in this patient, as oxygen is not available enough, so pyruvic acid will go into, yes, lactic acid, and this lactic acid will come to the circulation. And tissue has been, most of the vessels in the body during the compensatory stage, when they have been constricted, then many tissue have been ischemic for a very long time, and because they have been ischemia for a very long time for many tissues, these tissues switch their metabolism from aerobic to anaerobic situation. And during anaerobic glycolysis, there is massive release of lactic acid. So what is happening? That there is release of lactic acid from those tissues. Now when release of lactic acid is there, lactic acid acts as a vasodilator. Lactic acid acts as a vasodilator. Is that right? Plus lactic acid acts as a myocardial depressor. Plus lactic acid acts as a myocardial depressor. Now, when it is trying to vasodilate, now look at the sympathetic nervous system and angiotensin II and other compensatory mechanisms. Compensatory mechanisms were trying to vasoconstrict, but now these tissues are very angry. They have been giving sacrifice and yet patient is not in hospital and getting good treatment. So these tissues start producing lactic acid. Lactic acid start producing vasodilatation. Now there will be a fight between vasoconstrictor mechanisms which are compensatory and between the opposite mechanism like vasodilatory mechanism, and these vasodilatory mechanisms are like lactic acid or carbonic acid or carbon dioxide which is being produced by the tissue and not removed from there, right? So gradually the response of peripheral vasculature to sympathetic constricting effort will reduce. So we say at this stage, now tissue will become, peripheral vessels will become resistant to the vasopressor action of the compensatory mechanisms and they will start dilating. Now when they will start dilating, it means the blood which was already less in the circulatory system because patient was bleeding, so what will happen? There will be pooling of the blood. Blood will pool in the peripheral area. When blood will start pooling as vessels are dilating, venous return will be less. When venous return is less, cardiac filling is less, cardiac output is less. At the top, this lactic acid will directly also depress the myocardium, right? So, cardiac output will drop due to two reasons. Number one, peripheral vasodilatation, peripheral pooling of the blood which has started just now, it has reduced the venous return and cardiac output has become less. Number two, that there is a myocardial depression started and that is another contributing factor that cardiac output will be less. When cardiac output will be less, now listen carefully, when cardiac output will be less, then another trouble will start. Further hypoxia to the tissue, further lactic acid, further pooling, more reduction in venous return, more fall in blood pressure, further drop in cardiac output, and further lactic acid. So a positive vicious cycle will start. Do you think it's good for patient or bad? Yeah, it's very bad for the patient. Already he is losing the blood and now blood vessels start dilating. Then there is another trouble that sometimes hypoxia is so severe and prolonged that even endothelial cells are hypoxic and injured. And when endothelial cells are injured, these endothelial cells start producing nitric oxide. And this nitric oxide also contribute into further vasodilatation. Plus this nitric oxide also act as myocardial depressant. Do you think good things are happening to patient or bad now? There are very bad things happening to the patient, right? That in the patient's blood, lactic acid level is increasing, carbonic acid level is increasing, nitric oxide levels are increasing. All these things are cardiodepressant. At the same time, peripheral vessels are dilating. So now cardiovascular system, which was previously stabilized by the compensatory mechanism, now it is truly destabilized. Now patient's blood pressure will start falling significantly. Is that right? Meanwhile, when this mechanism is occurring, blood flow which was previously well maintained to central nervous system, will it be maintained now for the central nervous system? No. The central nervous system will not be maintained with proper perfusion, and lot of acid is going to the central nervous system. What is happening? Or carbon dioxide, right? Even vasomotor system is itself suppressed. Vasomotor system is itself suppressed. So it means sympathetic outflow will reduce. It means constrictor mechanisms will fail. And time is coming when compensatory mechanisms are shutting down, going down, and vasodilatory mechanism and myocardial depressal mechanisms are overwhelmingly active. Is that right? Not only this, another trouble will start meanwhile, and that trouble is that from the GIT. That GIT, when it remains ischemic for long time, when GIT remains ischemic for long time, because in early stage of shock there have been very intense vasoconstriction, supplanking vasoconstriction to GIT. So what will happen from GIT? Severe prolonged ischemia to GIT may produce necrotic patches and mucosa of GIT. When multiple small necrotic areas form in GIT mucosa, then bacteria from the GIT, from the broken mucosa, will come to the blood. And endotoxins and bacteremia and septicemia, these problems will start. Another bad thing happening. Another bad thing happening, right? So this patient has severe myocardial depression. This patient has vasomotor center failure. This patient has another tragedy. Look here. When endothelial cells were injured, I told you, number one, they will produce nitric oxide, which will produce vasodilatation. Number two, nitric oxide will produce myocardial suppression. But there was another thing. When endothelial cells are injured by hypoxia, they become more sticky to blood contents, right? They activate the coagulation mechanisms. This is the risk of DIC, disseminated intravascular coagulation. Number two, that platelets start sticking there. Microcirculation becomes fast or slow? It becomes slow, and sludging in microcirculation occur. So it's not acting as a good microcirculation which brings the new nutrients and removes the waste product. Is that right? So what we have learned, that lactic acid is more, carbonic acid is more, arteriolodilatory mechanisms are there, vasomotor center has flopped, myocardial depression is going on, GIT is also releasing different type of toxins to the circulation. Is that right? And last thing, that injured endothelium in multiple tissues become so much shrunken that fluids start leaking from the interendothelial gaps. So again, this is good or bad? It's bad. Is that right? So how many bad things happen? Lactic acid was there, carbonic acid was there, nitric oxide was there, endotoxins were there from GIT, lot of bacteria are there, and all these things fail the response of peripheral circulation to the vasoconstrictor mechanisms, right? Cardiodepression is there. And progressive cardiodepression and progressive dilatation of peripheral circulation will lead to more and more failure of circulatory system. Is that right? Now, as patient, now his blood pressure is falling. Even meanwhile, the acute tubular necrosis may have occurred to the kidney, because in the kidney, nephrons, proximal convoluted tubules, need lot of oxygen, and when they remain ischemic for a long time, even renal shutdown start, right? Even if still you reach to hospital, you can save your patient. If you give him blood, if you stop the bleeding, you replace the volume, right? You can save your patient, right? Right now you came out of the traffic jam and hospital is now about 15 kilometers away. You rush there, but patient is somewhere here. Right? Now, patient is coming down from this stage. He is entering into refractory and irreversible stage, and you are not yet in hospital. What is happening at this stage? Now we'll talk about the next stage and what will happen at that stage. We will come to the last stage. You are very near to the hospital, right? But patient is entering into refractory stage or irreversible stage. What happens at irreversible stage? That all the tissues and cells start committing suicide, right? Life is probably not worth living now. For example, for a long time up to now, by the time patient is at this stage, there is severe deficiency of ATP. If there is severe deficiency of ATP, do you think sodium potassium ATPases, which are present on every cell, will they be working? No. When sodium potassium ATPases are not working, these are sodium potassium ATPases. When they don't work, what will happen? Sodium will start accumulating in and potassium will start leaking out. Is it good? It is not good, right? That extracellular cations will start leaking in, like sodium and calcium are more outside the cells, so they will start coming in. And potassium is more inside the cells, so it will start leaking out. So it means cell membranes, in the absence of prolonged absence of ATP, cannot act as selective barriers, and they cannot maintain the calcium and sodium more outside the cells, and they cannot maintain more potassium inside the cell. So sodium and calcium are coming, and this is a sign of injury to the cell, and potassium is leaking out. This is number one. Then another trouble which is there is about the lysosomes. That let's suppose here is the lysosome. Prolonged deficiency of ATP plus lot of acidosis, acidic situation. There is a lot of acid present in the blood as well as in the cells. Because oxygen is not there, so lactic acid is being formed, and even carbon dioxide is not washed away, so carbonic acid is also accumulating. This will damage deficiency of ATP plus excess of protons. This will damage the lysosomes. So lysosomal enzymes will start leaking within every cell. Every cell has started committing suicide. But remember, you are very near to the hospital. But in the patient body, what's happening? From every cell, cell membranes are failing, lysosomal membranes are failing, and lysosomal enzymes are coming out, and these hydrolytic enzymes, hydrolases, they start damaging the local tissue, you can say intracellular structures heavily. Do you think now the cell is in good shape or bad shape? Mitochondria, meanwhile, in most of the tissues, mitochondria will fail as powerhouses. and now worst thing is going to happen. I told you that ATP level is now more or less. ATP level is less, and if ATP level is very less, rather cell is unable to make ATP, so it is converting all of its ATP into first ADP and then into AMP, and even phosphate is removed from there. What is left is adenosine. Again, let me repeat it, that ATP in the cell has been converted into ADP, then AMP, and eventually in adenosine. Adenosine can very easily come out of cells. Adenosine. And it will go into blood and convert into uric acid. And uric acid can never go back to the cells. It cannot enter into cell. And now you exactly reach to hospital. There is a very good intern there. Patient is of course immediately taken to the intensive care start. Blood pressure has fallen. Urine has in the blood. What he will do, if he is very wise and if he can do, he will stop the bleeding. He will stop the bleeding point. He will start infusing the colloidal solutions. Of course, best will be if he can get immediately matched blood. If blood is not available, he can give albumin, or he can give gelatin, or he can give different type of large molecular weight carbohydrates. He start infusing high molecular weight substances so that osmotic pressure in the blood become high and blood pressure should be maintained. Even his heroic effort becomes somewhat successful and cardiac function is going on still, patient is still alive, blood pressure even slightly recovered. But even he does the best thing in the world, more chances are patient will not survive. You know why? Because he has gone into advanced stage of irreversible. There have been irreversible injury to the cells. Cell membranes have failed by now. All biochemistry is disturbed. Potassium has gone out of the cells. Sodium and calcium has come into cell. Powerhouses, mitochondria have failed. Lysosomes have released a lot of destructive enzymes within the cell. And the worst of everything, attention please, the worst of everything, adenosine has leaked out into uric acid. Even if you supply the blood flow to the tissues, even if you supply the oxygen, even if oxygen go inside, is there any ADP to be converted into ATP? Is there any AMP? Even if there is no adenosine. So you cannot make AMP, you cannot make ADP, you cannot make ATP. So in this case, patient is even though living, but they say, experienced doctor will say patient has gone to which stage? Irreversible shock stage. He is bound to die. Recently, they started calling the irreversible stage with refractory stage because they have saved few patients from this stage. So this is very difficult stage to manage because when you give vasoconstrictor substances, vessels don't constrict. When you give cardiostimulation, heart cardiac output, and when you make the volume of the lost volume, you make it good, still cardiac output does not come up. They say this stage is refractory to treatment. But even at advanced stage of refractory, it really becomes truly irreversible and every cell has committed suicide and then you cannot do much. So in the last event, what really happens? That is resistant vasodilatation, which is not responding to vasopressor agents. There is severe myocardial depression and every cell is killing itself by releasing lysosomal products and by releasing its adenosine, and cells become extremely deficient in high energy phosphate reserves. Is that right? I'm sorry you lost your patient, but you traveled a lot. Okay, few more things. If you do autopsy of this patient, what you will find there? Number one, in central nervous system, you will find some neurons which are dead. In the heart, you will find some microinfarct type situation due to prolonged ischemia. In the liver, you will find that some cells, perivenular cells, they have undergone fatty change or they have been necrotic. In the kidneys, you will find cells in the proximal convoluted tubular area have been necrotic. In the adrenal cortex, it's very important finding, very commonly they ask in USMLE about it, that adrenal cortex cells which are usually rich in fat globules, they will be depleted of fat globules because those cells, as a last effort, they were trying to convert that fat to and make more aldosterone, or from that fat globules they were trying to make acid cortisol, right, and other products to fight the stress. Is that right? Then in these patients, if you study GIT, you will find microinfarct in the GIT. And in some of these patients, but more commonly in septic shock patients, you find that in the lungs, microcirculation has been heavily damaged and lungs have become edematous, especially in septic shock, and we say that there is ARDS, adult respiratory distress syndrome. So how many tissues? Central nervous system will have loss of neurons, heart will have loss of myocardial cells, liver will have hepatocyte necrosis, very prominently proximal convoluted tubular cell in the kidney have been necrotic. Is that right? And from GIT ulcerations are there, or you can say from GIT mucosal necrotic areas are there, and adrenal cortex, adrenal cortical cells, fat globules have been depleted in a very special function in the last moment of his life to convert the fat into aldosterone and to convert that fat globules or lipid rich areas into cortisol and attempt to fight with the stress, right? So now we will be discussing about septic shock. Septic shock, and septic shock is presently the #1 cause of death in intensive care units in USA. Septic shock is presently the #1 cause of death in ICU patients, intensive care units in USA. You know how many people die with septic shock every year with the best of the best care only in USA? 200,000. 200,000 people every year die only in USA with the septic shock, right? And septic shock has mortality somewhere between 25 to 50% mortality. It's a very high mortality. And this is all the data from USA, not from the third world. And the worst of the news is that with all our advances in understanding the organisms and antibiotic and chemotherapy, the worst of the news is that septic shock cases are progressively increasing. You know why these days septic shock is getting more common day by day? Because chemotherapy, cancer chemotherapy is more commonly used. So more people are immunosuppressed. Because steroids like drug or other immunosuppressive drugs are more commonly used for transplant patient or for the patient with autoimmune diseases, right? Or of course, patient of AIDS are also increasing in number. So what really happens that in this modern era of medical sciences, there are more people who are immunocompromised than ever before. The more people who are living longer, more people who are living for a long time with diseases, there are more people who are taking anti-cancer therapy, there are more people who are taking immunosuppressive for autoimmune diseases, there are a lot of people who are taking immunosuppressives for the transplant reasons. So due to all these reasons, naturally this big portion of population which is immunosuppressed, right, this segment of population is very, very vulnerable to more infections, and many of these end up with the septic shock, right? What really happens before we really go into septic shock, I want to know what is the term bacteremia means. There's a term called bacteremia. There's another term called septicemia. Septicemia. You must know what is the difference in bacteremia and septicemia. Then there is another condition called endotoxemia. Endotoxemia, right? So can you tell me the difference between these terms? That first of all you have to tell me what is bacteremia. Yes, what is bacteremia?
Bacteremia is when some bacteria
Present in the blood.
Yeah.
And how bacteremia is different from septicemia?
Yeah. The septicemia is when the blood infected when the endotoxin.
No, look. Do you think today you got bacteremia? Did you get today bacteremia? Did you get daily bacteremia? Answer is yes. Bacteremia means simply the presence of bacteria in the blood. Presence of bacteria in the blood. When you toothbrush, few bacteria do enter in your microcirculation. So the GIT, small cracks in the lumen of GIT or in the mucosa of GIT, some small bacteria enter into blood, right? So what really happens, that bacteremia is one of the common things. You are working in kitchen, you get a little cut, some bacteria do enter. Is that right? So bacteremia is a very common phenomenon, that bacteria may jump into your blood. But in a person who is and these bacteria which regularly keep on entering or occasionally keep on entering into your circulation, these bacteria are caught by your defenses and destroyed. So bacteremia is not very rare. Is that right? It's something common. You do shave in the morning, and if you produce a cut here, you get bacteremia. Is that right? Septicemia is a very horrible situation. Bacteremia is something not that dangerous. Septicemia is a really big problem. Septicemia means bacteria are present in your circulation and they are actively multiplying. That bacteria are using your blood as a blood culture. Right? This is a very big difference. Just bacteria inadvertently enter into your blood and then they are caught and destroyed by your immune system. This is called bacteremia. But if bacteria enter into your circulation and they start actively multiplying and damaging, the condition is called septicemia. Endotoxemia means that in your blood lot of endotoxins are present. Endotoxins are special lipopolysaccharides which are specially present in gram-negative bacteria, lipopolysaccharide. Endotoxins are special type of lipopolysaccharide which are present in gram-negative bacteria. You know the difference in gram-negative bacteria and gram-positive bacteria? Gram-positive bacteria has inner membrane. This is gram-positive. Gram-negative bacteria also have inner membrane. But the difference is the gram-positive have lipid bilayer and outside that it has lot of peptidoglycan layer. What is this layer? Gram-positive have a very thick layer of peptidoglycan. Right? Gram-negative bacteria have very thin layer of peptidoglycan and they have additional outer lipid bilayer. They have one more lipid layer. So gram-negative positive have only inner lipid layer and outside they have peptidoglycan. Gram-negative have inner lipid layer and then outer lipid membrane, and in between that it has a thin peptidoglycan layer. Now, in gram-negative, when we say that there are outer lipid layer, in this outer lipid layer, there are special type of lipid A. This is a special type of lipid A. And this lipid A has a core carbohydrate. It has a core carbohydrate, and with that, it is having polysaccharide tail. Again, let me show you here. There is lipid A. This is lipid A, right? Lipid A, and with this lipid A there is core sugar, and with that there is a long tail of polysaccharide. Remember, in all gram-negative organisms, lipid A and core protein is same, but in different gram-negative organisms, polysaccharides are different. In different gram-negative organisms, polysaccharides are different. So we can say that whole this structure is called, yes, endotoxin. So endotoxins are mainly present in gram-negative bacteria, and all the gram-negative bacteria have lipid A and core sugar same, but from bacteria to bacteria, for example, Salmonella, Shigella, Serratia, all of them have endotoxins, but their endotoxins have same lipid A, same core sugar, but they are having different polysaccharides. Is that clear to everyone? So you can say polysaccharide is unique to a particular group of gram-negative bacteria. Gram-positive bacteria and fungi do not have endotoxins. Gram-positive bacteria and fungi do not have exactly the molecule like gram endotoxins, but gram-positive have some similar molecules, like these are called endotoxin-like molecule. Endotoxin-like molecule, but gram-positive bacteria do not have any true endotoxins. Is that right? It means that, what is the difference in endotoxin and exotoxin, by the way? What is the difference between endotoxin and exotoxin?
Exotoxin is when a bacteria produce toxin outside in the blood.
Okay.
And endotoxin is when a bacteria produce your toxin.
Okay, let me tell you. Endotoxins are the toxins which are integral component of bacteria. Write it down. Endotoxins are the toxins which are the integral component of bacterial structure. They are usually released when bacteria die. When bacteria fragment down, then endotoxins are released. So endotoxins are the toxic substances which are integral component of the outer lipid membrane of gram-negative bacteria, and they are usually released when bacteria die. Gram-negative bacteria start dying, endotoxins are released. Exotoxins are released by the living bacteria, right? So endotoxins are the part of bacteria, but exotoxins can be released by the bacteria. Now the point which you should remember, that exotoxins can be released by gram-negative as well as exotoxin can be released by gram-positive. This is exotoxin. Exotoxin is the substance bacteria can release when it is living itself, right? Another point which is important, let's compare endotoxin and exotoxin. Number one, endotoxins are limited only to gram-negative bacteria. Exotoxins may be from gram-negative or maybe from gram-positive. Number two, endotoxins are integral structure of the gram-negative bacteria. Exotoxins are not the integral structure. They are released by the living bacteria, right? Number three, endotoxins, all of them work in the same fashion. Endotoxin come from Salmonella, or endotoxin come from Klebsiella, or endotoxin come from E. coli. All the endotoxins damage our body in the same way. But exotoxins for different bacteria produce different effects in the body. Exotoxins from different bacteria produce different effects in the body. For example, there is exotoxins called, coming from the bacillus tetanus, that produces tetanus. But different exotoxin come from the bacillus botulinum, and that produces a disease, flaccid paralysis, right? In the same way, there are some exotoxins which act as an enterotoxin and produce diarrhea and nausea. So what I am saying, that different bacteria produce different types of exotoxins, but all the gram-negative bacteria produce same type of endotoxins as far as lipid A is concerned, because lipid A in all the gram-negative bacteria's endotoxin is same, and it is the lipid A which is a more dangerous component which is producing the disease to us. So we can say that from three different bacteria, if endotoxin enter into three different patients, listen, we take endotoxins from three different bacteria and inject into three different patients, all patients will develop the similar problems with endotoxins. But if you take exotoxins from through different type of bacteria, inject in different patients, they will get different diseases. Endotoxins act generally, exotoxins act specifically. For example, some exotoxins work only on the nervous system. Some exotoxins work only on the heart. There are some exotoxins which damage only the kidney. So exotoxins go for a particular target tissue, but endotoxins have general effects. Then another thing, very important, you already know structure of endotoxin is lipopolysaccharide. Structure of endotoxin is lipopolysaccharide, and structure of exotoxin is usually a protein. That is a protein exotoxin. Is that right? It means endotoxins are relatively heat stable, but exotoxins are destroyed by the heat because proteins are damaged. So we can say endotoxins are heat stable, exotoxins are heat labile. Now we come to the most important difference. Usually endotoxins do not induce the antibodies. If I give you injection of endotoxin, you will not make antibodies against endotoxins. So our immune system does not protect us against endotoxin if you have a previous attack. But against a specific exotoxins, usually our immune system make antibodies. Because exotoxins are proteins and our immune system love to make antibodies against the foreign proteins. Is that right? Due to that reason, many exotoxins can be used as vaccination material. Right? If you take an exotoxin and partially alter it, partially change the exotoxin in such a way that exotoxin can activate the immune system but cannot produce disease, such exotoxin is called toxide. What is it called? Toxide. What is toxide? Exotoxin which is altered in such a way that exotoxin will not produce a disease but still activate the immune system. Right? Then it means that if such toxide is injected into your body, you will make antibodies against that substance. But if I inject you repeatedly with endotoxin, you are not going to build any immune response. It has a big significance that if you suffer with one endotoxic attack and you recover, you are still vulnerable to another attack in your life. But if you get, let's suppose, you suffer with diphtheria and toxin and you survive, then you are having immune defense against that. Am I clear? Any question here? Right? Now, this discussion was just by the way that I wanted to tell you what is endotoxemia. Endotoxemia is a condition when your body has a lot of gram-negative organisms and those gram-negative organisms are dying, and when gram-negative organisms are dying, endotoxins are being released from their structure, right? And 70% of septic shocks are, about 70% of the septic shock are due to endotoxemia. It means that 70% of the patient who die with the septic shock, they were having gram-negative organism. Is that right? Because gram-negative produce endotoxemia. So you know what is bacteremia? It is the innocent situation, benign situation in which bacteria are just present in your circulation. Septicemia is a condition in which bacteria are not only present, they are bacteria are beating your defenses and they are multiplying actively into your blood. And endotoxemia is a condition where gram-negative organism has released a lot of lipopolysaccharides into your circulation. Am I clear? Another condition is called pyemia. I would be impressed if you tell me pyemia. What is pyemia? Pyemia is a condition when pus from some area directly enter into circulation. We call it pyemia. What is pyemia? When pus from some area, right, enters directly into circulation, we call it pyemia. Is that right? Pyemia. Pyemia is a condition. For example, you have an abscess here, and if abscess rupture into a small vein and some pus enter into vein and pus globules are moving into blood, we say you are suffering with pyemia.
So it's more dangerous than any of the others?
Yeah, it can turn up eventually into septicemia. When bacteria will start multiplying in the body, it's very dangerous. There is another condition, but that confuses like that. Empyema. Have you heard of empyema? How it is different from others? Have you heard of it or never? On the surgical floors, how empyema is different from?
Infection.
Yeah, it is infection. All of them are infection, my friend.
Right. It's infection in the
Empyema is localized collection of pus, localized collection of pus in an epithelial lined area. Look here. Here is your liver, and you must be knowing these structures, I hope. Is that right? Now look here. If in the gallbladder, lot of pus is collected, what is collected? Lot of pus is collected. Now this pus which is present in the gallbladder, this is called gallbladder empyema. What is it called? Gallbladder empyema. right? From sometimes focus of empyema, lot of bacteria enter into your blood and produce septicemia or septic shock. Okay, you must be knowing what is abscess. What is abscess? What is abscess? Localized collection of pus. That is it. Localized collection of pus. Right? Anyway, these were just a few terms we were talking about. We have already discussed septic shock is a very dangerous situation. It is the #1 cause of death in ICUs in USA. Every year, more than 200,000 people die simply by septic shock only in USA. Right? Mortality rate in this patient is very high. With all the modern management, mortality is somewhere between 25 to 50%. And then I've told you that these patients are day by day increasing because more and more people are immunocompromised these days due to AIDS and due to cancer chemotherapy or due to immunosuppressive drugs, right? Then I was talking about that, and I've already told you that 70% of the septic shock are involving endotoxic release. Now I'll tell you exactly how the endotoxins work. Are you interested to know how the endotoxins work? Right? How the lipopolysaccharide work? Because if you know how the polysaccharides work, lipopolysaccharide work, then you really know how most of the gram-negative bacteria can produce endotoxic shock. Right? So we will talk about now how the endotoxins work. Look at this bacteria first. This is the bacteria, this is its inner membrane, and this is its outer membrane, and this is having peptidoglycan as a sandwich between the inner membrane and the outer membrane. So what you call this situation? This is a happy bacteria, but if it dies, right, it will release, what it will be releasing? Lipopolysaccharides, that is lipid A with core sugar with oligosaccharide chain. Now, lipopolysaccharide, let's suppose this is a lipopolysaccharide which is released by the bacteria. This is a lipopolysaccharide. Now, when these lipopolysaccharide come, one of the very important function of lipopolysaccharide is that if they are released into your circulation, if these lipopolysaccharides are released into your circulation, they will bind with special proteins, and these proteins are called, what are the name of these proteins? Yes, lipopolysaccharide binding proteins. Right? You may be thinking why I'm going into this detail. There's a very latest trend that they're trying to find the drugs which can neutralize these proteins, right, or alter this protein anyway. Lipopolysaccharide bind with these proteins, and after that they will eventually go and stimulate the endothelial cells. They have a capability to stimulate endothelial cell, or they can stimulate monocyte or macrophage. Let me tell you, if there's one cell here, suppose this is a macrophage cell. Now what these lipopolysaccharide will be doing, that this lipopolysaccharide will bind with the special type of receptors on endothelial cell, and this special receptor is called, the very special receptor, right? And you know what is the name of this receptor? CD14. It's a special type of protein, right? What really happens, that this will be transferred to a particular target cell, which may be endothelial cell or which may be a macrophage or monocyte. Once this reach here, now this, what is this? Lipopolysaccharide bind with which molecule? CD40. This will bind with the CD40. Bind with the CD40, right? After once binding with the CD40, what it is doing, that there is one more molecule which is called toll-like molecule. Toll-like This is called toll-like receptors. Then what really happens after binding here, right, the CD40, then it will stimulate the toll-like receptors, right? And when it will stimulate the toll-like receptor, it will give signal to this cell nuclear machinery. And within this cell, its genes will be activated. This genetic material will be activated and it will produce, of course, messenger RNAs, and from here it will start releasing a lot of dangerous substances, and these substances are different type of cytokines. These are different types of cytokines, right? So what did we learn? The lipopolysaccharide bind with its binder protein, they reach to the target cell, which are usually endothelial cell and what is this funny thing? Macrophage monocytes. There they bind with CD14. Again, what's the importance of this to learn? Now they are trying to make some drugs, some injections which are just having soluble CD14. They are having soluble CD14. If we inject the soluble CD14, look here, if we inject the soluble CD14, then this will bind with the soluble CD14, but soluble CD14s are injected from outside. So this will become busy with that and it will not have enough concentration to attack our real cell. This is one of the pharmacological approach in near future may be coming. That they are thinking the patient who have endotoxemia, they have very high mortality. If you inject them with CD14 molecules, then a lot of endotoxin will bind with CD14 molecule, and then they will not go to the those CD14s which are present on our cells. So they cannot activate our cells. Am I clear? They are intercepted on the way. Then look, these endotoxins. So what really lipopolysaccharide do? Lipopolysaccharide activate endothelial cells and macrophages. This is the right, and monocytes, and then these endothelial cells and macrophages, they produce a lot of what? Cytokines. And these are the cytokines which produce the clinical features which we develop in endotoxic shock. Right? These are the cytokines which are elevated in blood in very high concentration, and these cytokines basically produce damage to us. One more point which is very important, that when endotoxins work on the endothelial cells, there is endothelial cell activation. There is endothelial cells activation. They are activated endothelial cells, number one, and they will release more nitric oxide, and this will lead to strong vasodilation. More nitric oxide. Endothelial cells under the influence of lipopolar endotoxin stimulation will produce a lot of nitric oxide, so most of the blood vessels will dilate. If most of the blood vessels will dilate, you know what will happen? You will go towards shock. If many vessels are pathologically dilated, blood will pool into peripheral area, you will develop distributive shock. Is that right? Plus endothelial cell will shrink and some fluid will be also lost outward. So when you have septic shock, many blood vessels are dilated, right? And those blood vessels which are dilated due to cytokines activity and release of nitric oxide, right? Even these days now there is a modern trend, they are trying to build a drug which can neutralize nitric oxide. Is that right? They are working a lot, 200,000 people die. So they are working a lot to find some way to intercept the function and tragedy induced by the lipopolysaccharide, right? So what they are thinking, that maybe if some drugs can be injected and they can neutralize nitric oxide, vasodilatation is reduced. Because in septic shock there is massive vasodilatation and blood is distributed in the peripheral part of the body, and venous return is reduced, cardiac output is reduced. Of course, due to this vasodilatation in patient of septic shock, pulse is rapid and bounding, not thready weak pulse. There is strong pulse and palms are warm. But in case of hypovolemic shock due to vasoconstriction, body become cold, hands become cold. So face and the hand become cold and clammy in case of hypovolemic shock due to severe vasoconstriction, right? But in case of septic shock, there is severe vasodilation. Is that right? Due to that reason, some people call this warm shock. What do they call it? Warm shock. Number two, many of these patients may have fever also. But when I talk about fever, you must know every patient with septic shock does not have fever. And there is something very surprising. That 15% of the patient with septic shock have hypothermia. Hypothermia. Why I am telling you this thing? That don't expect that every person who has septic shock would have high temperatures. Unfortunately, there are some people who have even hypothermia. I will talk about why. Because many toxins act on the hypothalamus and disturb the temperature regulation. And 5% of patients with septic shock never develop fever. They remain normothermic. 5% of patients remain normothermic, normal temperature. 15% of temperature less than normal. Of course, what is left behind? 80%. These 80% have fever. These 80% have fever. Is that right? So, these 80% have fever. Now, see that this is gram-negative organism, and when it disintegrates, it releases a lot of endotoxins. Endotoxins bind with lipopolysaccharide binding proteins, and eventually they get transferred to the cells which are having CD14 molecules. These cells are monocytomacrophages as well as endothelial cell. They bind with CD14 molecules, and these lipopolysaccharide activate toll-like receptors, and these receptors give signal, and under the influence of those signals, these cells start producing cytokines. They start producing cytokines. Now, the different cytokines are produced as a wave. First of all, this production of interleukin 1. Okay, first of all, in the blood, there is a high level of lipopolysaccharides. That is followed by high level of, yes please, high level of polysaccharide lead to the production of lot of tumor necrotic factor. And after some time, you will find there is a high level of interleukin 1. After that, you will find high level of interleukin 6 and 8. Then there is a high level of platelet activating factor and nitric oxide. So, what we really see that in the blood of the patient, the dangerous thing which appeared first of all was lipopolysaccharide. And lipopolysaccharide, when it stimulated endothelial cell and especially macrophages, the macrophages produce lot of tumor necrotic factor in the body. Tumor necrotic factor activate more macrophages and more endothelial cell, and lot of interleukin 1 is released. Interleukin 1 act on many tissues, but in low concentration it will act on endothelial cells, and endothelial cells will release interleukin 1, 8 and 6 and 8. And eventually all the endothelial cell and all the macrophages will start producing very dangerous substances like platelet activating factors, so that coagulation system will disturb, and they will also produce lot of nitric oxide, so there will be massive dilatation in the body. So what we really see, that lipopolysaccharide lead to release of cascade of cytokines in the blood. Lot of cytokines are released in the body. Now these cytokines, when they are present in low concentration, low amount, they are good for us. They help us to kill bacteria. But when these cytokines are more, then they become dangerous for us. Now let me tell you how these cytokines are dangerous for us. Now we will talk about that what happens when cytokines are in low concentration, and eventually what happens when they are in high concentration. Let's suppose there is a patient here, and this is his circulatory system. Of course, now we'll see what are the effects of cytokines on the body. Here is your patient's pulmonary system, and there lies its liver, right? Here is bone marrow house, and then of course we should not forget you have something very good, and that is called central nervous system, having hypothalamus here with anterior and posterior pituitary. Now, what really happens when bacteria are releasing endotoxins, and endotoxins are activating the monocytes, right, as well as these are activating the endothelial cells. right? In low concentration, first I will talk about in low concentration what happened, that this lead to, number one, activation of, this is neutrophil, this is monocyte. So activation of neutrophils and monocytes. So it means when bacteria come in our body, endotoxins, they stimulate our white cells, and white cells become more active. When white cells become more active, the formation of bacteria. So in small concentration, these cytokines are good for us. Is that right? And these lipopolysaccharides lead to the formation of cytokines, and cytokines are good for us. And of course, cytokines activate the endothelial cells, and endothelial cell undergo interendothelial gaps are formed as endothelial cells are activated, and that releases antibodies in this area, and that releases complements. And even in low concentration, we can say that cytokines in low amount, what they are doing? The cytokines are doing following things. Number one, activate white cells, neutros and macros. So it's good or bad? Number two, they activate endothelial cells, and endothelial cells produce edema fluid and release this increased permeability, and that leads to, you can say, release a little bit nitric oxide, so locally blood vessels become dilated so that more blood can come into injured area. And in the same time, they break down C5a and C3a. I mean, they break down the complement, they activate the complement, right, the cytokines. And if complements are fragments C5a and C3a are produced at the site of inflammation and bacteria, these complements also help in removal of bacteria. Is that clear? For example, C5a can attract more and more neutrophils, right? And C5a and C3a both can activate mast cells, and local inflammation will be produced. So up to now it is good. So when cytokines in low concentration, this is good, that they produce local effect, and those local effect enhance the inflammatory action, and they enhance the innate, you can say, immune system, and help in elimination of bacteria. But when cytokines become moderate concentration, now they will start some other things. Number one, cytokines with moderate concentration will move to the liver. Cytokines with moderate concentration will go to the liver, and they will activate the liver cells, and liver cells will start producing the proteins which are called acute phase protein, acute phase reactants. That when these cytokines become more in number, right, they will go to the liver, they will force the liver to release certain types of proteins which are called as a group acute phase reactants or acute phase proteins. These proteins also help in elimination of bacteria. But remember, some of these proteins also contribute in rising ESR, and some of these protein is called C-reactive protein, and the protein which is out of this group, which is called C-reactive protein, that is diagnostically used to check that is there any inflammatory condition in the body or not. Then some of these cytokines will go to the bone marrow, and from the bone marrow they will release what? Neutrophils. So patient will develop neutrophilia. Again, it is good for the patient. The more neutrophil which was stored in the bone marrow, they will be released in the blood, and that will lead to better ability of the body to eliminate the bacteria. But and of course, we should not forget that some of these cytokines will go to the hypothalamus, and they will disturb temperature regulation center, and especially interleukin 1 and tumor necrotic factor. When they go to hypothalamus, they produce locally in the hypothalamus, they produce PGE2, and under the influence of PGE2, prostaglandin E2, temperature center is disturbed and fever start. Again, let me tell you, if cytokines are in low concentration, infection is less, you don't get fever. But if there is a lot of cytokines, then they will go to the hypothalamus, especially interleukin 1. And interleukin 1 will bind with hypothalamic cells, and those cells will release PGE2, prostaglandin E2. The prostaglandin E2, which is released within the hypothalamus, it will change the temperature regulating center, and patient will develop fever. fever, right? But if cytokines are produced further, yes please.
Yeah, I just want to know what receptor interleukin-1
Okay.
binds to in the hypothalamus.
Oh, that's very interesting. He want to know that which receptor,
You said it.
okay, which receptor is present in hypothalamus on which interleukin-1 binds. Answer is that is called interleukin-1 receptor.
No, okay, well, what was it that you said about EPT?
Okay, look. It is like this. Interleukin-1, first step is interleukin-1 should bind there, and interleukin-1 will lead to the formation of prostaglandin PGE2. PGE2 will change the, here, PGE2 will change the thermostat in the hypothalamus. For example, it will give the order for shivering. So shivering, so person will produce more temperature and it will produce cutaneous vasoconstriction, so that more temperature is produced but temperature of heat is not lost. So patient temperature start going up. Am I clear?
Okay.
How the fever is produced? Interleukin-1 binds with the hypothalamic cell, the local cell produce PGE2. PGE2 can alter the temperature regulating center in such a way that hypothalamus give the order to the body to shiver. So there is more heat production and there is less heat loss because there is cutaneous vasoconstriction, right? So more heat production, less heat loss, fever will be there. Am I clear?
Okay.
Now, but in some patients, concentration of cytokines become very heavy. Now I'm making them red. Cytokines become very dangerous. When their concentration become very heavy, number one, cytokines damage the endothelial cells a lot in high concentration. Interendothelial gap form, lot of nitric oxide is produced, lot of platelet activating factors are produced. Severe vasodilatation occur all over the body. When severe vasodilatation occur, now it's going to be a shock. The blood pressure start falling, because all the body vessels dilate dangerously, so peripheral pooling of the blood occur because blood is abnormally distributed in the body, and because blood is too much distributed and the pooled in the peripheral vasculature, so effective venous return is not there, cardiac output drop and patient goes into shock like situation. So now we'll see patient is entering into septic shock, right? So there is massive vasodilatation and this dilatation is by the nitric oxide which is produced by the cytokine action and lipopolysaccharide action. With that, platelet activating factors are also released and which produce generalized inflammation, widespread multi-organ inflammation, because platelet activating factor control every step of acute inflammation. Platelet activating factor can lead to endothelial activation, increased permeability. Platelet activating factor can activate neutrophils and macrophages. Platelet activating factor can augment almost every step of acute inflammation, and nitric oxide leading to massive vasodilatation in the body. Is that right? Meanwhile, some of these, of course, many blood vessels, right, in which when platelet activating factors are active, those blood vessels may undergo a process of DIC, small blood vessel, disseminated intravascular coagulation. The coagulation process is activated in massively in all over the body, right, and that may also, what will happen? That lot of platelet activating factor and activated endothelial cells, they activate the coagulation system. Now if I'm the patient, all my body coagulation system is activated. I say there is disseminated intravascular coagulation. But when coagulation system is activated, all the coagulation factors are consumed. Suddenly, plasminogen convert into plasmin and plasmin start breaking down the fibrin. So all the fibrin which was made due to coagulation, all that fibrin break down, and suddenly in the blood, fibrin breakdown product become more and patient develop anticoagulant state. So patient passes through two stages, first procoagulant stage and then anticoagulant. Again lesson, widespread activation and damage to endothelial cell and lot of platelet activating factor. Everywhere coagulation process start, all the coagulation proteins are consumed and lot of fibrin is produced. Then anticoagulant system is activated and all the fibrin is broken down into fibrin breakdown products, and after that, do you think blood has any more available coagulation factors? No, all the coagulation factors have been consumed. That is why other name for DIC is coagulation factor consumption coagulopathy. So all coagulation factors have been consumed, and now body does not have procoagulant system. So person start bleeding from multiple sides. From IV line patient will bleed, from wounds he will bleed, maybe from nose he will bleed, from mouth he will bleed. So some patient will start bleeding from multiple area, and we say that they have developed DIC, right? One more way, more thing which happens in this patient is that lot of cytokines activate the endothelial cells in pulmonary circulation. You know, this is pulmonary circulation. Endothelial cells in pulmonary circulation are too much activated and injured. A lot of neutrophils and macrophages are stuck there, and they start damaging the pulmonary structure, and lungs develop severe dysfunction, and this condition is called, yes, what is it called? ARDS, Adult Respiratory Distress Syndrome, and here was vasodilation. That is why it is warm shock. So massive vasodilatation, risk of DIC, and there is a high risk of ARDS, Adult Respiratory Distress Syndrome. Person develops severe distress in respiratory system due to massive damage to microcirculation of the lung, as lot of endothelial activation occur in microcirculation, lot of neutrophils and macrophages are activated there, and there's severe damage to microcirculation of lung as well as alveolar structure, right? We call this condition. And in the end, what will happen? That very high concentration of cytokines does not only produce vasodilatation, you should not forget to mention that very high concentration of cytokines also act as a cardiosuppressants. So we can talk about these cytokines in three waves, three stages: low amount of cytokines, moderate amount of cytokines, and high amount of cytokines. Again, let me repeat. In low amount of cytokine, they just activate local white cells and local endothelial cell and complement activation. It is all good to remove the bacteria. In moderate amount of cytokines, systemic effects start. That acute phase reactant proteins are produced. From bone marrow, what is released? Neutrophil are released, and fever starts. In very high concentration of endotoxins and very high concentration of cytokines, then the real problem start, that massive production of platelet activating nitric oxide factor and other cytokine, massive vasodilatation, cardiovascular system collapses, right? High risk of DIC and ARDS is also there. So eventually what will happen to these patients? When blood pressure will keep on falling, is that right? And eventually they will die of septic shock. But before the death, because blood is pooled in the peripheral area and heart is not receiving any venous return to produce significant cardiac output. So multiple organs develop severe ischemia due to hypoperfusion. So multi-organ failure start. What is the term used? Multi-organ failure start. Central nervous system fails, liver fails, kidneys fails. So multi-organ failure start. One thing which I want to mention more, that in some septic shock, right, this was something about endotoxemia, but some gram-positive organism and some fungi also have some molecules like endotoxin, not exactly endotoxins, but some gram-positive bacteria and some fungi have similar molecule to endotoxin, and they can also produce the effects like this, and patient may go into septic shock. You know, endotoxins are typically produced by gram-negative. But some gram-positive and some fungi do have some molecule which have action like endotoxin, but they are not endotoxins, structurally not endotoxins. So gram-positive bacteria and fungi can also produce septic shock like this. This is one thing. Second thing, that some bacteria produce a special type of antigen which is called superantigen. Some bacteria produce a special antigen which is called superantigen. What is the function of superantigen? Superantigen can activate many group of lymphocytes. Usually a normal antigen activate one specific type of T cell, but superantigen can activate many different type of T cells. So what really happen, that if there is superantigen will produce activate lot of macrophages and lot of T cells, right? Because superantigen has a capacity to cross-link the macrophage on one side, superantigen can hold the macrophage on one side, hold the T cell on other side, and superactivate both of them. So what will happen? if superantigens are released in my body due to bacteria, superantigens will activate lot of macrophages, lot of T cells, and all the macrophages and T cell will release lot of cytokines, and again picture like this can be produced. Is that right? The classical example of this is toxic shock syndrome toxin. You know toxic shock syndrome toxin? This toxin is produced by, this is not endotoxin, this is exotoxin. Toxic shock syndrome toxin is produced by Staphylococcus. How it was discovered that in America they found there were some young females who died, suddenly developed rash, and very rapidly these young females developed hypertension, and then they died with multi-organ failure. They were not understanding what's wrong with them. Then they came to know these females were using intravaginal tampons, and these tampons were having special type of staphylococci which produce toxic shock syndrome toxin. And those staphylococci from the tampons, they release lot of toxin in these females' blood, and these toxic shock syndrome toxin activate lot of endothelial cell, activate lot of macrophages, because this is superantigen, not endothelial cell. They activate a lot of macrophages, lot of lymphocytes. When in these females, lot of macrophages are activated, lot of lymphocytes are activated, the massive release of cytokines, and that will produce rashes, and that will produce cardiovascular collapse and multi-organ failure and death. Is it clear? One thing which is important, that how do you investigate these patient, right? Again, never forget, even though these are the patient in shock, the peripheries will be cold or warm? They will be warm usually, but they are not as cold as it happened in what? Hypovolemic shock. But still you should remember, some of these patients do have hypothermia. Is that right? Anyway, in laboratory investigation, what you will do? In the laboratory investigation, you will find neutropenia, but more commonly neutrophilia. Right? 50% of these patients have destruction of platelets. So 50% of patients in septic shock have thrombocytopenia. About 3% of these patients have coagulation abnormalities, and now become the most important investigation. If you suspect septic shock, you have to rush up for the treatment, but if possible, you must take 3 blood samples for the culture for 3 different veins in a very short time. You should take 3 blood samples from 3 different veins in a very rapid succession in a short time, and send it to the laboratory for the culture, and then give the antimicrobial cover. Is it clear? We will not go to the management of this. The management of this will be discussed in medicine. Class dismissed.